ओके. याचं रेकॉर्डिंग चालू करायचंय का?
Started.
हो, एक मिनिट. Good afternoon and welcome to this warm Wednesday afternoon. Okay. I think somebody is talking very loudly. They'll have to mute themselves. Good afternoon. A very good afternoon and okay. The echo होता है. Somebody is talking very loudly. They'll have to mute themselves. If you are logged in from two devices, please disconnect one, Vaibhavi.
Okay.
Okay. Echo होतोय. मला वाटतं तू YouTube वर पण काहीतरी म्यूट करावं लागेल.
एक मिनिट ma'am, I will mute everyone. I will mute everyone now when they start. एक मिनिट ma'am, I will mute everyone.
Actually, suppose somebody has joined from nearby two devices now. If you mute everyone also, then it will be there.
So Vaibhavi has logged in from YouTube and from Zoom. So that is the problem. तू त्याचा व्हॉइस लो करून टाक YouTubeचा.
Technical, somebody must be there. Will guide.
So त्याचा व्हॉइस लो करून टाक YouTubeचा.
Technical, somebody must be there. Will guide.
So त्याचा
व्हॉइस कमी केला मॅडम.
पण तरी एको येतोय.
दुसऱ्या रूम मध्ये ठेवून घेते असं कर.
I think can again log in, log off and log in again.
व्हॉइस कमी केला मॅडम.
पण तरी एको
दुसऱ्या रूम मध्ये ठेवून घेते असं कर.
Again log in, log off and log in again.
व्हॉइस कमी केला मॅडम.
पण तरी एको Stop YouTube recording. Just do hair recording.
Again log in, log off and log in again.
Stop recording of both and start moving on Zoom. Stop YouTube recording. Just do hair recording.
Okay.
Now is it fine?
I think it is not the problem of YouTube.
Then somebody is logged in from two devices. No,
Now
I
it's
don't think
okay.
there is an echo now. Yeah.
आता गेला ना? गेला. Oh, here's one.
Yeah. Okay. Yeah. Good afternoon and welcome to everyone for our webinar today. And today's webinar is atopic dermatitis and more. Atopy and allergy, when I was a postgraduate student, was a very dry and itchy subject with me, and I was allergic to it. And I always thought that was an option. But when no sooner I came into practice, I realized that the itch and the scratch and the wheeze and the cough is something that we are going to see every day. And as the days pass and as we are so-called progressing, I think with development, allergies and atopy is on the increase. And when we put things for option, someone has to come to our rescue. And today we have someone like that, who's a specialized immunologist and allergist, Dr. Vijay Varad. It's our immense pleasure, Dr. Varad, to welcome you to our forum and to address us. Let me share my presentation. Is this visible? Just a minute. No, I think I have to go to share screen.
बॅकग्राऊंड व्हॉइस कुठून येतोय?
नाही येतो, नाही येत. Can I just, I don't know what has happened. Dr. Vijay, can you project your screen, your slide, see the slide?
Can you see the slides?
Yeah, but your CV slide, I can see your new era in management of atopic dermatitis.
Actually,
You don't have it.
I did not copy on that because
Yeah,
I had,
yeah.
it's okay.
Yeah, no problem. So let me just read out because you're such a illuminary today. So I think it's just fair that I should read out your CV. Today we have friends Dr. Vijay Varad with us, who is a consultant allergist, pediatric pulmonologist, and a clinical immunologist who is practicing at Pune. He has written 21 papers at national and international, read international papers in conferences. He is the founder faculty member of the allergy chapter of IAP. He's a master trainer in asthma, and he has presented 2 e-modules in IAP on food allergy and chronic urticaria in 2021. He has been national faculty for the HOPE module, Newer Advances in Management of Allergy module 22. He has been a speaker for the chest, ENT, eye, dermatology, pediatrics, family physicians, and an organizing chairman for the 2022 annual conference of National Indian College of Allergy and Asthma Immunology. He has been among the 7 experts for appraisal of international guidelines of World Allergy Organization Prevention Committee for Food Allergy, Atopic Dermatitis. And he has also been an expert on the review panel for the European Journal of Pediatric Respiratory chapter. So today we have someone who is an author in books on allergy, and he has conducted more than 57 national and international trials as a principal investigator. With such an illuminary in our midst, I welcome you, Dr. Vijay Varad, and please go ahead with your talk today.
Thank you, Anjali ma'am, for kind introduction. पालघर बरोबर माझं फार जुनं नातं आहे, कारण माझं ग्रँडफादर झाल्यामुळे माझी 6 महिने इंटर्नशिप पालघरला होती. त्यामुळे त्या मेमरी मला फार आठवतात पालघरच्या. ते बीच जाणं असेल, डिनर्स असतील आणि हेवी वर्क ऑल्सो. म्हणजे रात्रंदिवस जे डिलिव्हरीज असतील, हे असतील. So we learned a lot about MBBS, basically the practical experience, physiotherapy पासून ते सर्व काही डिलिव्हरीज वगैरे सगळं आम्ही पालघरलाच शिकलो सगळ्या मॅक्झिमम. सो इट हॅज as Amit called me like Palghar, so I reminded me all the memories and I was very excited. Next time definitely personally also I would like to, we have a allergy chapters, demystifying allergic diseases module also, so we can have a module. Recently 2 months back only we had that in Thane. We had a very good response, and regularly I come to Thane for the IAP. And as I was 14 years in Mumbai, म्हणलं की बाहेरचं वाटतं. And it's always a pleasure to be with my friends are also practicing in Palghar. So basically, allergy, as Madam already said, how the allergy is increasing. Most important is the genetics. And as we know, why the genetics change? Because of the environmental changes, the lifestyle, whatever the food we are consuming, the adulteration into the feed, that is causing more problems. So considering 30 to 40 years back, the allergy we used to see, now we are seeing a lot of cases. So you started this in 2001, like with integrated pediatric hospital. And along with that, 3 to 4 hours I used to dedicate.
Just a minute, Dr. Arup Roy, can you please mute yourself? Dr. Arup, yeah, thank you.
So hardly sometimes within a month, 1 or 2 patients used to be ready for the allergy testing, immunotherapy and all. But now since 2010, 12, we're seeing a lot of uprise cases into that. And since that, because of that 2012, I stopped the hospital and I am completely focused in allergy immunology, and I can see a lot of increased cases. And as Dr. Anjali Madam said rightly, the scenario had changed. So now, before that, symptomatic management was our aim. Whatever the patient comes with the complaints, we used to manage symptomatically. But now we have to think about the long-term management. So as a pediatrician, how we give vaccines and all to the children to stop the progress of the complications of that disease. Later on, suppose somebody has a flu or something, pneumonia and the altered in the mucosa into the respiratory. The same way in allergy, as a pediatrician, our role is very big into the community compared to the other practitioners, because most of the patients in an early stage they present. And as a pediatrician, you must be knowing, we are talking about allergic march. And in that, atopic eczema or atopic dermatitis is the most common disease. As a practitioners, we must have seen 80 to 85% of the patients, they overcome the eczema. But are we really doing a justice by treating just eczema? No, because we'll see the next 20-30 minutes why we should treat the root cause. So if you see the burden and the quality of life of these patients of atopy, any, not only eczema, any gastrointestinal symptoms like GRD, 40% have food allergy. If you see the even colics and all, like Hope module, we had a chapter on that. So in colics and all, many people have food allergy, cow's milk, protein intolerance, everything can be there. So as a pediatrician, if we can pick up those things, we can guide the patients according to that, rather than giving a overuse painkillers and antibiotics and all, which will again stimulate the allergy march, Th2 inflammation, and which leads to the further progress of the disease, the inflammation. So that's why you can see in this picture how not only the oral intake, but most of the children now, the guidelines have said that contact with the allergens, the dust mites, even the food allergens through the skin, the dendritic cells, they get first stimulated and they go on causing a Th2 memory. And this Th2 memory, as goes on increasing, and when the child has an exposure to that food again by the orally, the body, the mast cell or dendritic cell into the gastrointestinal tract will trigger the allergies. That's why many of the patients, they complain mostly food, but actually the primary allergens can be something different, which are in contact like dust mites, pollens or something. So we have to simply understand the pathophysiology of atopic dermatitis. It is a type 1 and type 4. It is a combination of that. That's why many patients, when they are in an early stage and when they have a mild atopic dermatitis eczema, immediately they respond to some antihistaminics or local steroids and all. But many of them, after it establishes, the disease establishes, then the patient doesn't show the same response what he used to show previously to the cetirizine, atarax or something. So we have to understand this acute phase where initially only histamine is released. And that's why antihistaminic, they showed the good response. But later on, as the disease go into the chronic phase, their Th2 inflammation happens more. And besides the histamine, other inflammatory markers they play. And again, type 4 hypersensitivity, like contact hypersensitivity, also increases. Then these patients don't show that response what used to be previously. So then it becomes difficult. So considering these things like cesarean born children have more allergies than antibiotics or paracetamol in the infancy, changing the gut flora, which leads to the further slow introduction and IG or pro-inflammatory responses, again, decrease into the short chain fatty acid, Th2 inflammation, and these interleukins. Like during the COVID, we must have been knowing, like how the interleukin IL-6 and all. The same way here, IL-4, IL-5, IL-13, the B cells are stimulated. And then the change in the lifestyle, diet, and all that triggers. So if you see, even the 2017, as a part of the review author, we had a lot of discussions on this and how we can prevent the allergies and all. Like in 2019 to 2023, working with the World Allergy Organization, first time we have come up with the food allergy, atopic dermatitis prevention committee, and how we can guide. So come to this example, very practical one. Like this child had a GRD, and this patient was treated for that. Then child had a eczema, atopic dermatitis. Again, he was treated by the dermatologist and all. Then he started having cold, throat infections, cough, and he was treated with the symptomatically. Now, even there are the real-time data that tonsils, throat infections, adenoids, sinusitis, these are secondary infection, mostly because of the primary Th2 inflammation. So in that, mostly it is a allergy. Few of the patients, then depending on the exposure to the surrounding, if any industries or a very high pollution, indoor or outdoor, that also can have around 15 to 20% patients Th inflammation. But this child was referred by the cornea specialist with early cataract because of the repeated eye steroids, periocular eczema, which was not responding, and 6 months he was at home. His quality of life was so poor. The other children used to bully him. Why you are having this? So when the child is in the infancy period, 2 to 3 years, 4 years, no problem. But in your practice also, you must have seen now, it is not only children. Now even toddlers, adolescents having severe eczema. Even adults, I am seeing a lot of adults also, not only pediatric. I see the adult patients also. I have seen a lot of eczemas and increasing later on. So in between, there is a window period. In the later on, the patient, when has a established disease, he will have a severe eczema. So this Th2 inflammation, this slide is very important. So remember, while managing, our role is very important. So not only just symptomatically, but to stop the Th2 inflammation. So I think, like, most of the allergy patients have been given a lot of steroids. Amongst that, the localized steroids and eye steroids have a lot of side effects than the nasal and inhaled corticosteroid. So these children with the atopic dermatitis have been pumped up with so many steroids. Only the brand names are changed, but they are applying the local steroids. They get absorbed. Even our colleagues and all dermatologists, they just speak about that he don't use steroids. But practically, if you see those prescriptions, even oral steroids are also so much given to these patients. So what will happen? Not only the local, but the oral steroids will cause so many complications. And if you see, like, as I already told about the dendritic cells, these are the primary immune like responses they got sensitizing, and later on the re-exposure of allergens will cause more inflammation. And again, type 4 hypersensitivity also plays a role into these severe or moderate to severe atopic dermatitis patients. So these Th2 types of chemokines, cytokines, they have the very important role in pathogenesis in these skin lesions and dermatitis. So immunological way, we have to manage this Th2 inflammation, and in turn, the interleukins like IL-4, IL-13 and all. So even that there are treatments as a target treatments, not only just symptomatically, but there are target treatments now. So as already I spoken about that, these bottle feeding, cesarean delivery, maternal, any nowadays, a lot of even younger women are smoking, drinking and all, their lifestyle, that is again changing the things. Increased Clostridium E. coli because of the unhealthy diet. We know a lot of children are having a junk food now. This imbalance of the gut flora is very important. So most of the time, we have been already educated about the moisturizer use. Ample amount of moisturization should be used in this patient, which normal pH balanced soap should be used, which steroids are safer, like hydrocortisone or desonide or something. That already we are listening to many of our colleagues, dermatologists, pediatricians and all. So I will not go into that therapeutic part because each and everybody of us are treating these patients. And according to our own practice, we know our favorite molecules are some molecules and we prescribe that. But depending on the immunological or allergic pathway, I will discuss as an allergist immunologist. So in that, besides this moisturization, soaps, or oral steroids, oral antihistaminics and all, the probiotics now play a very big role in most of the treatments now. Not only the atopic dermatitis and all, now even the respiratory probiotics are there. Already for the diarrhea and all, we are using probiotics since many years, irritable bowel syndrome, ulcerative colitis and all. Even there is now gut-brain axis. So even ADHD, autism also probiotics are playing a role. So they are everywhere. So what are these? These are suggest that have a role in the treatment of food allergy by maintaining the intestinal epithelial barrier integrity, suppressing intestinal inflammatory responses, inducing the mucosal IgA production and tolerogenic immune responses, as well as allergen-specific B and T cell responses. Administration of these alters the gut microenvironment by promoting a change in the local microflora and in cytokine secretion. It could potentially modulate the toll-like receptors and the proteoglycan recognition proteins of enterocytes, leading to the activation of dendritic cells and Th1 response. So basically here, long-term wise, the Th2 to Th1 response is also very important. Even recently, the bacterial host interaction may induce the expansion of T regulatory cells and expression of immunomodulatory cytokines such as IL-10 and transforming growth factor beta. So these T regulatory cells and IL-10 is very helpful. Even in the COVID, you must have seen those the study was found, both people we had a good IL-10 had a less cytokine storm. So these IL-10 and these specifically transforming growth factors and T regulatory cells are very important in these patients. So this gut flora, if you see, there are different type of lot of mechanisms of probiotics in our area. So considering today's topic, like which safer molecules in atopic dermatitis is the probiotics. They should be used than the oral steroids and localized steroids much. Whenever a very acute case, the secondary infection, infected eczema, then combination of acetic acid with mometazone or something can be given. But long-term wise, because we know as most of the patients, moderate to severe atopic dermatitis will require for long-term management. So there, the safer molecules should play a role. So while having a probiotic, it should have a external processing should be good, survive on the shelf in the pharmacy, viable in the gastrointestinal environment, adhere to the gastrointestinal epithelium, produce the antimicrobial substances, modulate the host immune response and metabolism, demonstrate the clinical benefits. That's very important. So popularly used probiotics microorganisms are Lactobacillus acidophilus group, Bifidobacterium, Lactobacillus reuteri salivarius, Bacillus clausii, Bacillus subtilis, Lactobacillus rhamnosus GG now specifically. Not rhamnosus, rhamnosus GG is used very regularly, and Saccharomyces boulardii. So as a practitioner, Saccharomyces boulardii and Lactobacillus was used for as a diarrhea, but now there are very good probiotics. So if you see the action of these probiotics is improving the IgA, phagocytosis, Th1 response, interferon gamma, TNF, beta factors, as well as reducing the IL-4, IL-5, IL-13, improving the IL-10, and reducing the Th2 inflammation. So these, not only the enzymatic or on the interleukins also, inflammatory marker also, it has a very good efficacy. So they are absorbed into the lymphoid tissue and they act on the T cell and B cell also. So which are the best one, like therapeutically efficacious in atopic dermatitis? Because these probiotics, as we previously saw, how these changes into the short chain fatty acids, leaky gut, and the contamination with the Staphylococcus aureus, Malassezia, purpur fungus, and all, they in turn cause the imbalance of the Th2, Th1, interleukin secretion, and then inflammation, leading to the Ig production, which will have a mast cell stimulation, leading to the inflammatory marker release. But if you see the gut flora, how the Lactobacillus salivarius, specifically today, I'm talking because I'm using it a lot in my practices. Specifically Lactobacillus salivarius, Rhamnosus GG, these few are very helpful for a atopic dermatitis. So they reduce the colonization of the Staphylococcus aureus, Malassezia purpose, they correct the leaky gut, improve the short chain fatty acids, they reduce the pH, then improving the IL-10 T regulatory cells, switch to the IgA production, reduction in the Ig, and reduction in the Th2 inflammation and the symptoms also. So this balance will be there. So which are the clinical trials basically? There you can see, like in the pediatric population, for 5 months, 43 patients were analyzed from 0 to 11 years. Even now I am doing a clinical trial up to age of 12 years. Around more than 45 patients we have analyzed till now, and I am finding a very good results in these patients. So this, in this CORAD square, as well as the quality index of the itching and different type of rash, the size of the rash and depth we are analyzing, the moisturizer, micrometer also I am using, and we have found a very good results in these patients. So safety, efficacy into the pediatric population also, you can see the reduction into the CORAD score, around 70% of the children had that, and each intensity was reduction in 80% of the patients. Then adult study also for 5 months, 38 participants were analyzed and the CORAD assessment was made in the beginning, and quality index also was analyzed, and there was significant reduction in the CORAD and improvement into the quality life. So again, in the adults also, After 16 weeks, you can see the 52% reduction in SCORAD score. So this is the pictures like before how, and after the treatment, the patient had a very good improvement. Okay. So if you see the comparison with, this was the study done with the other things, and you can see the improvement into the SCORAD score compared to this. This is a very good example. This was child who referred to me around the age of around 1 to 2 years, and he was shown to many dermatologists. The child was actually referred to me for the repeated cough cold, requiring 2 times admission into the pediatric ICU with severe bronchitis with secondary infections and all. So you can see in this picture how the skin is coming out with so much significant eczema, all the face. You can see the long eyelashes over here. And this child, for the parents, it was so cumbersome. They could not take him to any of the social gatherings. Everybody used to ask them. So they used to be always indoors. They were so scared going outside, the dust will trigger it and all. And once the child was brought to me, we did a testing. It was a dust mite and milk sensitivity was significant. We started avoiding the milk and we started desensitizing along with the good moisturizer, a normal pH soap. Whenever very severe, some places where the second infected eczema, then localized mometasone with flutic acid and all, and ample amount of moisturizer. How much should be there? The child should be dipped into the moisturizer. A good moisturizer should be used. Even now there are probiotics added moisturizers also shown a very good efficacy. So it should be taken in a very ample amount and just kept it that way. Even after the bath, the child should not be completely dry. It should be just pat dry. And immediately after pat drying, the moisturizer should be used in a very ample amount. That's very important. That is the most important treatment in any atopic dermatitis eczema patients. Moisturization, there is no other excuse. We have to use because to improve the barrier of the skin, to reduce the contamination of staphylococcus, other organisms or Malassezia purpura and all. So the good moisturizer, along with that, for the itching, we gave him cetirizine and all. Montelukast also was added for 6 months. But after the desensitization, within 9 months, you can see how the clearance after 1 year, the child is showing such a good response. It was miraculous. This patient has referred me more than hundreds of patients till now. So basically, the allergist and immunologist role also is very important because even there are documented data now. See, in medicine, there are always 2 ways of thoughts. So you don't look at the European, whatever the things, considering our population, the lifestyle has changed. Our so much crowded population, the flats, there is no sunlight and all, dust mite increase has been more, adulteration into the foods and all, again increasing the food allergy. So we can specifically, when there is a significant history in the family and all, we can do some allergy test in some of the few patients. 30% can have a food allergy, even 60 to 70% can have a dust mite or other sensitivities also. And if it is clinically correlating, we can help these patients a lot. And specific avoidance and specific immunotherapy in some cases will definitely help these patients. It's my practical experience. See, you can see this patient, still the long eyelashes are there, slight flaring of hallucination, slight protrusion of the A and the turbinate hypertrophy. That also we are taking care now is much better. This was also another child who had a significant eczema, was not reducing. After the treatment with the specific moisturizations and even the probiotics we gave him for a longer period, and slowly within 6 to 9 months, he started showing a very good response. So you can see like how the lactobacillus exposure can have a very good results. Even in the village journal, it has been mentioned. This was the radiologist child from Srinagar Road. She had been already, the child was around 11 years old. Last 6 to 7 years, he was taking a treatment. Initially, it was told her like within 5 to 6 years, he will overcome, but still it was not reducing. Then she came to me from some of the colleagues. And when we started treating her with the rest of the, like, as I said, from moisturization to some simple precautions, allergy tests, like she had a parthenium, ज्याला आपण काँग्रेस ग्रास म्हणतो, गाजर गवत, 65 किलोमीटर पर्यंत ट्रॅव्हल करू शकता. Even it can go with the vegetable and fruits in the homes. And again, she had a dust mite sensitivity also. And Pune and Mumbai, like cities, pigeon feather and droppings is a very significant allergy. Many of the patients we have seen in the pigeon feathers, there are 17 types of dust mites. Again, amongst that, the blomia is also contaminating the pigeon feathers, which is very important allergen. And these also can travel around 2000 meters. So such type of specific tests also in these patients definitely help. So even the World Allergy Organization guidelines, when I form a module for the Indian Academy of Pediatrics on the food allergy and all, I went through a lot of literatures and all, and I found even where there is a significant history into the family, and if the child is going to suffer, the probiotic use during the pregnancy also has helped to reduce the severity into the next generation. As allergy prevention programs, like we are guiding to the parents, like before the marriage also, they can be screened properly and they can be guided on some of the simple precautions and all. Now, besides the probiotics, biologics is playing a very big role. Now we are using omalizumab, mepolizumab, benralizumab, as well as we are using the dupilumab. Specifically in atopic dermatitis, dupilumab has been approved about 6 months also in USA. They are using regularly, very safe, considering those patients with a severe atopic dermatitis, which require a repeated oral administration or parenteral administration of steroids, or even a local skin also, the child requires a repeated steroids. If it is causing a thinning of the skin, it gets absorbed locally also into the systemic effects. So those patients, we can use such type of molecules. These are biologics. They have the target delivery at the interleukin site. So the dupilumab, which has a very good IL-5, IL-4, as well as the IL-13 effects. So directly targeting and reducing the symptoms very well and very good without any side effects. Even nowadays, for the atopic dermatitis, JAK inhibitors, one of the trial I am doing for the severe urticaria and eczema for the JAK inhibitors, but they have some side effects of after phase 2 trial. Phase 4 trial also should be analyzed, and then we can talk about that. But at present, it is not available in India. Dupilumab also, the trials are happening now. Even previously, it was only advised by the dermatologist, but now allergists also can write it. And I have used my 2 patients with the special precautions, and special permission has to be taken as it is not freely available. It takes around 15 days to 1 month, and the patient can have slightly costly. But those patients which have a very poor quality of life, around adolescents which go to the college and all, for them it is miraculous. I mean, they have a very good results. You can see like how it has a targets on the interleukin 4, IL-13, both involved in the pathogenesis of the skin problems and all. Even eosinophils present in the biopsies have been, and the mast cells and basophils which have been improved, and the score also has improved in these patients because of this. Then again, allergen-specific immunotherapy. So selective patients, the selection according to the experience and skill, it is very important. So we select the some of the patients of these for the test also. We do the test, and some of the patients which have a clinical correlation in the midnight, early morning, having a severe itching and all. So that can be because of the rust mites into the bed, and we have tested for them, and we have given some simple precautions, avoidance measures, like the bed can be put into the intense sunlight. The dust mite proof covers can be utilized for these patients. Again, there are nowadays pest control for the dust mites. There are specific ultraviolet as well as the highly powerful vacuum cleaners. They remove the dust mites onto the bed, sofa, into the car cushions and all. Because in the car also, the dust mite and the fungus is very common. It is a very high pollution in the car. Daily, we shed around 1.5 gram of skin, hours, and one person sheds around 1.5 gram. 1 gram of skin, more than 10 lakh dust mites can survive. So imagine in a bed, crores of dust mites are there. If the patient is sensitive to that significantly, the child will have a repeated triggers in spite of whatever the medications we are giving. It's like a diabetes patient having an insulin based, but he is eating 10 gulab jamuns. What will happen? So his sugar is going to shoot up. He will require a more insulin increase in the dose, and that way. The same way here, some of the specific patients in my practice since many years, I have found selection and selective allergy testing is very important. So while treating the patients of all allergies, the first important is the allergen exposure. If you go on any of the sites, any of the university sites or any of the country specific also, the exposure of that allergen, what the specific precautions has to be given. Then mast cell stabilization should be achieved with the anti-inflammatory oral medications also. Safer one, about 2 years, can be bilastine, hexofenadine, desloratadine, about 6 years. Then cetirizine is very good in children. They tolerate very well. Sedation is not much found. So even in USA also, cetirizine is very well used. Some of the patients, if it's itching, it responds to hydroxyzine and all, they also can be given. Then, as I said, the biologics also can be given in some of the patients. And then, if required, then desensitization or immunotherapy. So as a pediatrician, our aim should be to stop the atopic march. So most of the patients with eczema or gastrointestinal symptoms, they start it. And later on, they go into rhinoconjunctivitis, rhinosinusitis, asthma, chronic respiratory disease. Even now, asthma COPD overlap syndrome is there. A lot of people are showing that. So adult COPD is now second death causing disease in India. So as a pediatrician, our role is very important, not only symptomatically, but to stop the progress of the disease and the complications. So this minimal persistent inflammation should be managed properly to achieve the symptom control and to stop the progress of the disease. Even since 1998, World Health Organization also has published a paper that to stop the disease progression, the specific precautions and the safer medications are very important. And considering many of the people will say testing is costly, nothing as compared to the, if you see even the vaccines, whatever we are giving, they are more costly than the allergy management. Because if you go for the newer vaccines, the cost is 2,200, 4,000 and all. Here, hardly per allergen, 100 rupees is the cost. So selective allergens can be selected. Immunotherapy despite also, whole for 1.5 to 2 years, it is hardly 8,500 to 12,000. So it's very safe and cheaper also. And the medication score also comes down, improve into the quality of life also, and long-term benefits also. So these type of practices should be implemented in our practices, and we should give a very good benefit to the patients. So our aim should be symptomatic relief with the safer medications. Like as I said, ample amount of moisturization, safe probiotics also. If required, then biologicals to the patients, and some of the patients, the desensitization also should be implemented. And if the high risk patients are, preventive measures during the pregnancy also the mother can be treated very well. So even when I had been to the dermatology institute of the Munster University, I found regularly they are analyzing these patients properly. They are doing some specific tests also. Even moisturometer is also used, and the SCORAD scores are utilized into the practices. So there are all these are available online also. And if you want some of them, I will share with you. We can use in our practices, and it will be really useful how we monitor the spirometry and all in asthma patients and all. The same way here, we can use these monitoring purposes, and it will be really useful. Thank you. Thanks a lot.
Thank you so much, Dr. Vijay. And I just wanted to ask you, what is the SCORAD score? Yes, actually, SCORAD score is basically according to the symptoms. There are different type of scores have been analyzed. How we use a pulmonary index into the asthma. Same way, itching, the rash, size, which parts are affected. It is a standard one. I mean, it can be seen on the Google everywhere, and you can just note it down. Even picture score is also there, and the graphical score is also there. So we can use it that way. Will you share that with us? You said you will share some. Yes, sure. I will share it. Yeah. Right. Then I can share it with our. You can share, definitely. Anyone has any questions? What is the role of cyclosporin in severe eczema? There's a question. Yeah, basically, cyclosporin is used in severe urticaria, and other is an immunosuppressant. But considering the side effects, it has a very lot of side effects. So rather than I will say you use biologicals first. If the patient doesn't respond, then go for the cyclosporin. If the patient is very poor and all, then we can go. But still in eczema, rather than eczema, it is more recommended in urticarias. Any other questions? I wanted to ask you, Dr. Vijay, what is the role of coconut oil? Is that practice valid? And any moisturizing oils are definitely good. And coconut oil has been already used in India a lot. Only sterile precautions are very important, because some of the patients, we have seen some infections also. So at least it should be a little bit warm, and then it should be lukewarm, and then it should be used. Because if the contamination happens, and look at this one also, because nowadays a lot of adulterations are there, so it should not trigger. So I will suggest you that as the sensitivity has increased nowadays, and there is a cutaneous sensitivity also, so ask the parents to apply first a smaller amount, then slightly increase to the other body parts and all, and then check it. Otherwise, it should not trigger it. Otherwise, if it suits to the patient, then better, no problem.
because all the patients can't afford all these.
Yeah. So I just
and-
thought whether, yeah.
Definitely. Yes.
Second question is, if lactobacillus is so freely used, is dahi a good option for a probiotic in children?
Basically, see, traditionally, all our things are always good. Okay. So in day-to-day life, as a maintenance therapy, we can say, these things has to be used. But now the patient is already,
No, not for a symptomatic patient.
yeah,
but as a
symptomatic, you
preventive.
can have that much anti-inflammatory effect. That much curd has to be consumed.
Yeah.
Okay, to have that much extract. So these, whatever the billions or millions of lactobacillus are used into this, these are in a therapeutic dose. So it's always better to use the therapeutic dose.
Yeah. Any other question? Nilesh, any questions? Yeah. So,
I
yeah.
had one question, ma'am.
Yeah, please go ahead, Amay.
Yeah, my question was, sir, there are so many allergy tests in the market. You know, I have had an experience that I've seen variety of somebody doing immunocap, somebody doing immunoassays, then skin testing. What is the gold standard? What should you really believe? And if at all you have to recommend a patient, what we should be advising?
Yeah, actually, very good question. The allergy management is a very big topic. So I did not go into the details, but as you have opened up the subject, most important is that the ELISA testing and RAS testing, which is commonly done in India, it is outdated. It should be thrown into the bin. Okay, first thing is that it's outdated. It should not be done now. Now coming to the blood allergy test, if you want to go, then there are specific IgE, immunocap, or the component resolved diagnostic test are there in blood allergy test. Those are good. Only the panels of tests are not useful. If you suspect a food allergy, it is hardly 5 to 8% of the children have a food allergy. Rest of the children have a food intolerance because already their mast cells are hyperactivated and the gut mast cells get triggered by the histamine rich food. So it is not a food allergy, it is a food intolerance. So very few patients really have a food allergy. So always ask them repeatedly, after any food like milk, suppose it is a common milk allergy is very common in children. So even 2 drops of milk also, if the child consumes, and when the child is normal, and each and every time the same symptoms has to be there, that severity has to be same. If the child consumes 1 cup of milk or 2 to 3 drops of milk within 2 to 3 hours, then only it is a food allergy. There is no need to do tests for other patients. Whatever the food intolerance tests are done, these are misguiding to the people because into that the IgG is analyzed and that is a tolerance rather than intolerance. Whatever the report comes, it is actually the patient is tolerating to that IgG. It has already the IgG is formed, means that the patient is getting tolerance. That's why in intolerance test, the patient has so many positivities. So it is basically the tolerance is there. And it is a placebo effect. So what happens if the patient avoid it and they feel better, some of the patients. So it is mostly it is a placebo effect. So the even intolerance test should not be there. Now the skin prick test. Skin prick test is the gold standard. It is cost effective with the specific expert into that to select the allergens, and the healthy skin should be there. In most of the severe urticarias and eczemas, the skin is already hypersensitive. So we have to be very careful while interpreting the results. So limited allergens, we can check for these patients. Once we identify which is the sensitivity, we have to clinically correlate it. Suppose dust mite is there, then midnight, early morning, or exposed to some old cushions, sofas, whenever the child sits on the sofas, plays nearby that, he has more symptoms. Such type of symptoms should also collaborate. Suppose the child has an insect desensitizations. So after playing into the grass, or if they have a nursery in the balcony, if he visits there and plays over there, when the child handles the vegetables and fruits, so their droppings and dried feather also can be in contact with that child. So such type of clinical correlation also has to be analyzed because the allergy test will give a sensitivity. But practically, if the patient is getting symptoms or not, it always because of the clinical correlation. That has to be. So the very good question. Most important is that gold standard is still skin prick test. Even after the blood allergy test, we have to repeat the skin prick test if you want to give a immunotherapy or desensitization. Only thing, standardized extract should be there. There are a lot of people, they are using a localized extract, so are not much useful. Yes.
Thank you, sir.
Madam,
Thank
can
you.
I ask a question?
Yes.
Yeah, please go ahead.
Madam, sir has mentioned about that lactobacillus salivarius. So can he put more light on it, because I am hearing for the first time.
Yes,
He
sir.
told that it is very useful.
There are different type of strains into the market. So this is a research molecule, and there are already the trials have been done. Now Indian trials also we are doing now, basically, and it is showing a very good efficacy. So there are
But
different.
sir, is it available in the market
Yes,
easily?
it is available. Yes.
Can you tell us the brand name?
It's a tape AD sachets. It's a
Tape AD.
Tata tape AD. It's a Tata Inspira companies. Yeah.
Okay, so what will be the dose, sir?
In children's about 2 years, generally it is more safer and all. But I am using about 6 months also. And
Okay, so one
one
sachet
sachet in
per
a day
day.
for at least 16 weeks for children's. Above 12 years, it is 2 sachets per day for 2 months, followed by 1 sachet per day for 2 months. And if
Okay,
the
sir,
patient
another question. You have not mentioned anything about local steroid or leukotriene inhibitors. So are they outdated now?
No, sir. It's not that way. But as I said in my lecture, what I said is that they are already used it. People are using that. So, and repeatedly all the lectures since 1990, I am hearing the same topics. Like protein is better or mometasone is better. The same things are happening. So I did not feel that I should repeat the same thing. So it is not outdated. These are in acute condition, we have to use it to symptomatically. But repeated use will have a thinning and the again secondary bacterial flora. So repeated use should be not be promoted. Rather than that, the good probiotics and the good localized moisturizers are much better. And
So my last question. Suppose we have given
yes, sir.
we have given probiotic for 16 whatever period. Then how early we can repeat the second dose? Like
We
3
can
months.
continue also, sir. Depending on the patient's response. We can continue. I have used for 2 to 3 years also. Nothing much. And practically I haven't found any side effects. No problem.
Thank you.
Yeah, Dr. Vijay, what about, some other questions from someone?
Yeah, what's the role of methotrexate in treatment of acute?
Only thing is that it is an immunosuppressant. So as a physician, I will never like to use such type of molecules to cause a long-term side effects. So generally, I will prefer with and in my practice, at least more than 7,500 eczemas I have treated. I never use this cyclosporin methotrexate. I haven't used in a single patient also. I did not require it.
Dr. Vijay, what is the role of pets like a dog, cat in the house to allergy?
Very good, man. Very good question. Around 12 to 15% of the patients have a dog or cat sensitivity. Not only that, their urine sensitivity also. One of the senior pediatricians from Nasik had been to me with a very skin involvement since many years. So we did a CRD, component result diagnosis with me. It is a 60 lakhs machine. And we did that it cost around 18,500 to 20,000. But it picked up the dog urine sensitivity. So some of the patients, they can have a cat or dog sensitivity. And even these danders can travel around 15 to 16 kilometers. They are universal in India. So even I had a patient from Bishop School, 5 years old child, having a severe allergy. When we did a dog dander was significantly sensitive. And one of the teacher had a dog. In their house or in their close relatives, friends, there were no dogs. But the teacher had that. And then whenever she used to hug him, he used to have a more trigger. So these are universal allergens. And some of the specific patients, we can check it that way.
So is there a way to desensitize or so many donors ask us?
Desensitize also, but the desensitization has been more useful in dust mites, grass pollen, tree pollens, insects. It has been, but practically I am using for these danders also, pigeon feather droppings also. So it's all with experience and skill we develop these things. Definitely.
And the last question is dupilumab. What would be the cost in India?
At present, special circumstances, it is costing around 1,25,000. But once the DCGI approves, the cost will definitely come down. But
so 1,25,000 is a month's treatment?
Monthly. But it is covered under insurance also. These biologics are covered under insurance. And considering the oral and parental steroid and their side effects, it is much better. Because practical experience also. As a pediatrician also, I have practiced since many years. My family, there are many doctors. So I have seen all these things. And even like before the biologics use, we have seen the side effects of the steroids in many patients. So rather than that, the patients now, even my few poor patients, they got a aid from these MPWs when the situation was explained to the things. So now, if the patient tries, then he will get it.
So what is the duration of treatment?
At least minimum 1 year has to be given. Within 4 to 6 months, we have our results. If it is having a good result, 60% to 80% of the patient have a good result, depending on which biologics. Like omalizumab has a 60% patient have a good results, but dupilumab and all, 70 to 80% patient have shown a response, whatever the trials. My 2 patients, I got a very good results.
And would you recommend the same biologicals for asthma also?
Already I'm using it, omalizumab, mepolizumab. In Pune's first mepolizumab, I have only started in adult patients. And now also I'm doing one 12 years to 65 years old asthma patients, omalizumab trial. I'm using very regularly. In urticaria has also shown a very good response. Those patients which require steroids, at least more than 1200 urticarias I have treated with omalizumab. Very good results, definitely.
So those are reserved only for the very severe patients.
Yes, ma'am. It is always for severe. When the patient requires basically it has to be steroid sparing. Steroid sparing. It should not be used haphazardly. Those patients which require repeated steroids, oral or parenteral, and when we expect the patient will have a severe side effects of that, then we should go for that.
And would probiotic, Dr. Sri Sailam.
Yeah.
Oh my
Namaste, sir, Vijay. Namaste.
Namaste.
Regarding that dog dander and cat dander, it is very difficult for them to tell them, not to keep the dogs at home. But we have to remember that the dogs have that species specific. Some of the dogs are higher allergic and some of them are hypoallergic. So they can change the breed of the dog.
Yeah, but what with the dog who's already at home? You can't do it.
Okay. And one more thing is that regarding the cat dander, it is very higher allergic because of stickiness and of the nature of the dander.
Yes.
So cat dander is more allergic.
Yes, sir. Cat dander and even the cat saliva also causes a lot of problems. So it's a different. I mean, that topic is around 3 to 4 hours we have to talk. Allergen. I mean, it's a very vast topic. Still, I am learning actually day by day. Very nice to share, Dr. Srishalam. Very nice. Even now, there is a prophylactic treatment, like in an early stage. If the children are exposed to these domestic farm animals, I am doing a study, and we have found that they have less allergies, but they have exposed in an early part. So, as a preventive measures, if the child is exposed to the natural cow dung, आपल्याकडे जे गिर गाय म्हणतो आपण, त्याच्या काव डंग बरोबर हे केलं, एक्सपोज केलं, तर त्याचे एंडोटॉक्सिन्स जे असतात त्या काव डंगच्या ह्याच्यामधले, they are also playing a preventive role. So I am doing that also clinical trial. So basically, a lot of the things are there. We should do it definitely. Yes, sir.
Yeah, there were also some reports of early introduction of peanuts and other allergens in children. So
there is a leaf study as well as they have been found that 4 to 6 months during that period, the children are exposed to these. That's why in India, we don't have much peanut anaphylaxis because our children are very well exposed. The mother also during pregnancy eats the peanuts. And again, the boiled peanuts and all have a lesser allergy. So there are many things actually, and that's very good, definitely.
So there's a lot we can discuss, Dr. Vijay, about food allergy and other things. So I think today's has been excellent. Right from things which you said are very commonly used, like dip the child in moisturizer and then the common steroids, and right up to avoiding the allergens, and then on to biologicals, as well as you said that yes, you could use cyclosporin or methotrexate, but in your last so many years of practice you have not used. And you mentioned about allergen testing and the skin prick test of only specific components. So you have covered such a vast topic and yet so much to be learned. We've had a very participative audience. Thank you, Dr. Sri Sailam. Thank you, Amaya. Thank you, Nilesh, and thank you everyone who have asked such wonderful questions. And today we have a really lovely turnout, Dr. Vijay. And today we have 44 participants. So Thank you very much for your presentation. And on the same lines, today we were thinking of going ahead with allergic rhinitis, allergic conjunctivitis, and anaphylaxis. And we'd really appreciate if you are around. I know you are very busy, and you said that you have a clinic to attend now. But I'm sure we'll go ahead, and you have promised us that you will be online and do pass your comments. We are
Yes,
waiting for you to come to Palghar, and Palghar district is a very large district, covers right from Naigaon till Boisar and Vijayawada also. But Palghar is one of the main, places where you said you have done your. Are you from Grand Medical College, Mumbai?
I'm from
Yeah.
Grand Medical.
So I'm also from Grand Medical. I know that most people go to Palghar and they have a lovely vacation plus, service. So thank you very much. You are part of my alma mater. So I thank you for being with us. And a very big hand and applause to you, Dr. Vijay. We look forward to you being with us on many more. I hope we do the Hope module. And I think certainly in 2023 we will. So with that, I thank you for being with us today. And thank you, Inspira, for getting us such a wonderful speaker.
Thanks.
With this, we go to the second part of our CME today, and that is going through the standard treatment guidelines. We have so many. There are 106 standard treatment guidelines, of which we've had, I think, about 60 which have been published so far. The standard guideline book was released on 31st of this, I think last week on the 11th by Dr. Ambekar in the Central AP office at Mumbai. And that's going to be soon mailed to all of us along with the Purple Book of Immunization. So looking forward to that standard, but like we all know, we get it regularly Monday, Wednesday, Friday in our mail, but none of us open up and see. And I'm sure when we get the book also, we're never going to open it up and see. So today we've got people from our, very own community, all young, dynamic pediatricians, Dr. Amay Deshpande, Dr. Gauri Alos, and Dr. Nilesh Palwankar, who are going to read out this to us. And I'm sure we are going to have a great learning. So I request Dr. Amay Deshpande to present his standard treatment guidelines. Dr. Amay Deshpande is a young pediatrician with 20 years of experience, 25 years of experience, and very, very hardworking and dynamic. He practices in Vasai. And today he's going to talk to us about the central IIP guidelines and the standard treatment guidelines on allergic rhinitis. Over to you, Amay.
Yeah, thank you, ma'am. Good afternoon, everybody. What I'm going to speak today is about allergic rhinitis, the standard guidelines. And since these are standard guidelines, these are under auspices of the IIP Action Plan 2022. And there is nothing for me to speak about, but these are the guidelines which I think as pediatricians, all of us should be following in their practice. And it helps to have a universal, protocol in tackling our patients, and it helps everybody, especially our patients, if we are in the right track. So these are all evidence-based guidelines, and they have been programmed by a lot of luminaries in the group. And I'll be reading out one by one. It is just like a journal reading for us, but it helps us to revise our knowledge about allergic rhinitis. So I'll start with the definition and the burden of allergic rhinitis. Now, I'm sure since the corona epidemic has subsided and we are seeing the schools reopening, and lots of our pediatric patients are coming with these complaints of cough, cold, sneezing, frequent complaints. I think last time one seminar we had where Dr. Tanu Singhal and Dr. Yevle were talking about so many patients coming with fever and cough and cold, and all pediatricians have been helpless, trying and explaining again and again that this is what something will happen when the schools have reopened. But somehow I am seeing a sudden rise in allergic patients. Significant patients like wheezers are there, frequent cough and cold without fever. And I think there is an epidemic of this allergic rhinitis, probably because of It's my personal thought that maybe everybody was using mask. So the natural exposure which was happening was probably halted for a lot of time. And then it has come back with vengeance. So I know maybe this is one of the factors. So allergic rhinitis is a very common entity affecting 10 to 30% of adults and nearly 40% of children at some parts of their life. Almost 80% of asthmatics have associated allergic rhinitis, and around 50% of allergic rhinitis have associated asthma. So you can understand such a high load of allergic rhinitis and allergies in general. As per allergic rhinitis and its impact on asthma, that is ARIA. I'll use this as a short form as ARIA. AR is defined as type 1 hypersensitive inflammation of the nasal mucosa. Dr. Varada was talking about type 1 and type 4 hypersensitivity reaction. So this is type 1 hypersensitive inflammation. It is induced by exposure to allergenic substance with at least 2 of the 4 cardinal nasal symptoms, that is either sneezing, rhinorrhea, nasal itching, and a nasal block present for more than an hour every day on most or many of the days in a year. So what we talk many times, seasonal, it may not be seasonal, it is there all the time, perennial, I'll say. It is not seasonal, all the time, most of the time. So that is how these patients present, and they fit into the definition if any 2 of these 4 cardinal nasal symptoms are present. Basically, allergic rhinitis is classified in 2 ways, depending on the severity of the problem and depending on the duration. So they have clubbed into 4 types of allergic rhinitis depending on this classification. One is intermittent, mild persistent, moderate to severe intermittent, and moderate to severe persistent. The name itself tells you how the severity and the persistence of symptoms. So intermittent is the least troublesome. Mild persistent is little more troublesome. Moderate to severe intermittent, yes, furthermore, and very severe is moderate to severe persistent. These patients are suffering the most and all the time. So we have to classify our patients into that, because this classification will decide what type of treatment we can offer. Now, when we are talking about allergic rhinitis, so what all allergens can really trigger allergic rhinitis? So as we know, aeroallergens, outdoor as well as indoor allergens, dust, animal, insect allergens, house dust, the commonest thing, house dust mites, the most common, cockroach and pet dander. Sometimes occupational, teachers and students, they wipe the board, that chalk powder, some are allergic to that. Occupational, some kids might be working, you don't know. They are working in certain industrial areas, or they are doing household, there is some small scale industry in the house itself. The parents are using those things. The child might be allergic to that. Especially kids of painters, carpenters, they are all exposed. So these are occupational hazards. Latex is an important in healthcare professionals. We all know that. Gloves and all that, gloves related allergies and the powder which cause so much of irritation to our noses. Pollutants, indoor pollutants like biomass fuel burning. People have, farmers and all those things, they burn a lot of biomass. So biomass fuel is being used. We have gases and all, but there are still people who burn wood for cooking. So biomass fuel, tobacco, and gas pollutants. Outdoor, the commonest pollutants are ozone, oxides of nitrogen, and sulfur from diesel exhaust. We know all vehicles causing pollution. Drugs like aspirin and some non-steroidal anti-inflammatory drugs also can stimulate allergies, trigger allergic rhinitis in our patients. So that it is the comorbidities along with allergic rhinitis. The primary comorbidities, obviously, it can cause, ultimately we said so many patients can have asthma associated, sinusitis, otitis media with effusions, conjunctivitis, laryngitis, atopic dermatitis, and recurrent upper respiratory tract infection. That is what I think we are seeing in our OPDs recently, lot of URTIs with allergies. And obviously, because of this frequent URTIs and allergies, swollen adenoids, and then obstructive sleep apneas. These are the primary comorbidities because of allergic rhinitis. There are secondary comorbidities like decreased quality of life, adenoid hypertrophy, snoring, bruxism, dental malocclusion, learning and attention impairment, all because the child is not comfortable. He's not able to sleep properly, he's not able to eat properly. his quality of life is poor. So invariably the studies are affected. So how do we come to a diagnosis? How do we make a diagnosis that our patient has allergic rhinitis? So diagnosis of allergic rhinitis is based on detailed history. Characteristic signs, we have seen those signs, characteristic signs. We were talking about those 4 signs. And symptoms and the confirmed presence of allergen-specific IgE. Now that will come to the blood test. That's why I asked Dr. Varado, which is a more specific blood test. So the immunocap is one way to know, we can check it in blood. But skin prick, I don't think anybody does in skin prick. But yes, immunocap can be done. Certain labs do that. So that is how we can diagnose allergic rhinitis in our patient, from the history, from the characteristic signs, symptoms, and a confirmed presence of allergen-specific IgE. So allergen-specific IgE testing, either skin prick testing or in vitro specific IgE testing, have a supportive role in the diagnosis. It is very important that this test should be guided by a careful history and local aerobiology. So as doctor said, you have those allergens have to be specific. You can't check 150 allergens. It is of no use. It doesn't serve any purpose. So tests like total eosinophil count and total IgE lack specificity and sensitivity and is not recommended routinely. I do stand by this statement, but when we do a serum IgE levels, we find it high. Somehow it becomes easy to explain it to the patient that what your child is suffering is allergy, because they want a proof. Doctor कौन सा test बताएगा मेरे बच्चों का allergy? So you can't send everybody for a skin test, You can't send everybody for a allergy test, specific allergy test. But at least a general allergy IgE gives an idea that yes, the child might be severely allergic. A combination of patient education, self-monitoring, regular physician visits, avoidance of triggers along with pharmacotherapy is the cornerstone in the management of allergic rhinitis. We'll come to a flow chart which will explain it very nicely, and I think everybody should go through that flow chart once the book is available. All this that I've been speaking is easily explained in a single page flow chart, which is very good. So how to manage the allergic rhinitis? So to avoid areas with high pollen, fungal and dusty environment. So pollen, I know, gardens, you can't tell your parents, don't take your child to a garden. There's a lot of pollen there, but they will invariably go. But these are the places which ideally should be avoided. Fungal infections, moist conditions, dumpy houses, there are a lot of leakages, all those things can worsen the problem. And yes, dusty environment, unclean houses is not cleaned properly, dusty schools, dusty playgrounds, all those things can worsen the problem. Rigorous implementation of pest control measures. Why they are necessary? Yes, dust mites, the commonest allergen, is all the time around human beings, dust mites. So pest control system measures are there which can decrease this load. Control of house dust mites, avoid wall-to-wall carpeting, washing bed sheets in hot water and sun drying, putting mattresses in sun, dust mite encasing materials with very small pore size to prevent mite intrusion, reduction in relative humidity below 50% to reduce house dust mite concentration in the environment. I think these are good things to tell our patients' parents to avoid, because I think if you spend some 10-15 minutes with the parent who is so worried with his child's symptoms, all this thing they can willingly accept. Probably they'll follow your advice when they are so anxious to know what is happening to their child and why it is so frequent and repetitive. Coming to the pharmacological part of management, second generation antihistamines are drugs of choice in a mild intermittent AR. So that's why I said we need to classify our patient where he fits into mild, moderate to severe, intermittent, persistent. So accordingly, we can decide the treatment. So the drug of choice in mild intermittent AR is second generation antihistamines. The second generation antihistamines, all we know, are elaborated here. Cetirizine, which is the most commonly used, I think all of us commonly use cetirizine, quite effective. Sedation, I'm not very sure. I had only one patient with cetirizine causing extrapyramidal symptoms. I had seen because of an improper dose of cetirizine, but otherwise it's a very well tolerated cetirizine, a very well tolerated drug. Desloratadine, fexofenadine, levocetirizine, loratadine, Avastin, rupatadine, bilastine. So all these, but they are age specific. In certain age group you can use. The safest thing that you can use is cetirizine above 6 months or fexofenadine above 6 months, which I think routinely all of us use. Other drugs are basically depending on the dominant symptoms the child suffers. Like intranasal antihistamines are recommended above 6 years in children, but it should be better avoided for its bitter taste and somnolence. Intranasal antihistamines, I don't know, we rarely use them, but intranasal decongestants are being frequently used. They are also not safe to be used in kids. So we use saline drops. Oral decongestants are not recommended in children due to their systemic side effects such as irritability, dizziness, headache, tremor, and insomnia, and tachycardia and hypertension. Now, these guidelines are very specific, but I'm sure many of us do use oral decongestants because they are the most easily and universally available medicines. But keep it in mind when you're prescribing, it should not be for too long a duration, not a very high dose. It's very specific, and tell the patient that use only when really the child is too irritated, very much necessary. We have to tell them the side effects also, just to be careful and watch for symptoms. Inhaled nasal steroids are the control medications of choice. These are actually a gold standard INS in cases of allergic rhinitis because they really work well with least of side effects if used properly, and they are quite effective. So choose an INS with low systemic bioavailability like mometasone or fluticasone. I think these are the ones which are available in nasal inhaler, nasal spray forms. And a minimum dose required to achieve symptoms should be, you achieve the control over the symptom should be used, but they are recommended beyond 2 years because of convenience of use and obviously the safety. So to summarize about allergic rhinitis, to summarize about the INS use, technique of INS should be evaluated during each visit. As I said, it has to be used in the right way, right dose for it to be really effective. Allergen-specific immunotherapy is recommended in difficult to treat moderate to severe or persistent AR by a trained allergist. So as pediatricians, we may not be too expert in doing it till we really train ourselves in doing this, but moderate to severe and severe to persistent is best left to a trained allergist and a specialist. Sublingual immunotherapy and subcutaneous immunotherapy are the two most common modes of immunotherapy. Again, this should be done by a trained allergist because we need to actually do the skin testing and then come to a conclusion, to come to a diagnosis which the child really needs, and then do these things. So what are the commonest drugs used in allergic rhinitis? There are, according to the symptoms which you can choose, that is sodium chromoglycate. In cases of nasal itching and sneezing, it works better. Rhinorrhea, not much on effect on nasal obstruction and doesn't really work. Impaired smell, it doesn't really help. These people will still have impaired smell when you use this. So the best out of all this you can see is topical corticosteroids. Topical corticosteroids are the inhaled nasal steroids, I mean to say, and they are the most effective. You can see plus in each of the symptoms. Then topical decongestants only for the nasal obstructions. Otherwise, they're of no use, but they are the most commonly used. So you need to really know what medicines we are prescribing. I think my connection got lost. I'll just try. I think it will get reconnected. Just a sec. Is my screen visible to all? I'll just reconnect.
No, your screen.
No, we can't see your screen.
Yeah, I think it just got disconnected. Is
Am
it
I
visible
nasal?
now?
No.
Okay. You wanted to ask something, ma'am? Nasal what?
Yeah, you were saying nasal antihistaminics. They are oxymetazoline and hydroxymetazoline.
Okay.
Nazivion and Otrivin nasal drops. They are the nasal antihistaminics.
Okay. Actually, I am seeing that my screen is visible. I'll share again, just a second.
Yeah, you'll have to share it.
Yeah. Is it visible now?
Yes.
Okay.
Yes, sir.
Yeah. So we were talking about inhaled nasal steroids. The most effective you can see in all the symptoms is topical corticosteroid, that is inhaled nasal steroids, INS. So this flowchart I was talking about, flowchart for management of allergic rhinitis. Now, once we reach a diagnosis, once we have categorized our patient, whether it fits into severe or moderate persistent or severe mod, accordingly we start the treatment. So first, obviously, education of the parents, patients. If the child is big enough, you can tell him how things are happening and why are happening and how he should avoid certain things. If he is big enough to understand, yes, very good, he should be explained. Then avoidance of these triggers, we can tell them, and how the medicines are to be used. So once you have reached a diagnosis from the symptoms, then watery rhinorrhea, sneezing, itching of nose, nasal congestion, 2 or more symptoms more than an hour. Then we label them as an allergic rhinitis. Then we go to the treatment part. After educating the parents, patients, giving them an advice to avoid the triggers, and then coming to the pharmacotherapy. So mild intermittent, if it is there, if I've categorized my patient into mild intermittent, first choice of medicine will be a second generation antihistamines, and to be used SOS, not on a regular basis. When the symptoms are severe, you can use it because they are intermittent and they are mild, and these kids do just well by second generation antihistamines. If it is mild and persistent, then second generation antihistamines plus an inhaled nasal steroid or a leukotriene receptor antagonist, that is LRTA. So either of these things can be used. Moderate to severe intermittent is INS should be used. INH is again an inhaled nasal steroid, inhaled nasal antihistamine, and LTRA and immunotherapy should be suggested in such patients if affordability is not a major concern. And as Dr. Varad said, it is not so expensive now what initially it is to be. So we can still advise our patients to go for immunotherapy. And moderate to severe persistent, all probable things need to be used, what we are thinking of using in previous 3 categories: nasal saline irrigations, INS plus long-acting LTRAs, immunotherapies in severe rhinorrhea, and ipratropium nasal spray to be used in persistent runny nose. Ipratropium nasal spray I've never used personally, but I think this is a good thing. Some patients have really persistent runny nose and they're very irritable because of that, because leaky nose is actually a big issue in our school going kids. So the commonly used intranasal corticosteroids in allergic rhinitis are mometasone, fluticasone, and fluticasone propionate and fluticasone furet. And depending on the age, from 2 to 12 years, it is 50 microgram per nostril once a day, and about 12 years, it is 100 microgram per nostril once a day. So either 1 puff or 2 puffs, depending on the age of the child. Fluticasone propionate, 4 to 12 years, it is 50 micrograms each nostril once a day, and about 12 years, it is 100 micrograms each nostril once a day. Fluticasone furoate is 27.5 microgram per nostril once a day, and about 12 years, it is 55 microgram per nostril once a day. So below 4 years, the only choice of INS is mometasone. Above 4 years, you have all the 3 drugs which you can use safely. Or it can be used for 3 months. Ideally, that is what should be used. And this is a new knowledge, does not need weaning. Means I always used to think that we need to do weaning, but I now realize it is not weaning, but it is trying to maintain a minimum effective dose in a patient, which we think as weaning. It is not weaning, it is just to maintain on a minimum dose required. So you don't really need to taper it off. You just need to continue at a dose where the patient is asymptomatic. Obviously, regular monitoring and follow-up is required for checking for the vital for success of this therapy. Maintain minimum or low dose of INS to keep the patient symptom-free. That is what I always used to think as weaning, but it is not weaning. So, concluding my talk, allergic rhinitis is a very common respiratory disease affecting the quality of life and often overlooked, but can be managed effectively with a rational approach. And I think with these guidelines, it is very clear picture. This picture is very clear that we can easily manage our patients. Thank you. Thanks a lot.
Thank you, Amay, for that very nice presentation, because this is something we see every day. And I think there was one slide which said that if you do nasal secretion examination and you find more than 5 eosinophils, I think that would be a very useful way to know if you're seeing neutrophils or eosinophils to know whether it is allergic or infected. So thank you for that. Yeah. With that, we go to our next standard treatment guidelines, and that is by Dr. Gauri Alos. Dr. Gauri is also a very young, dynamic, and multitasking doctor, pediatrician practicing at Vasai. And she's today going to talk on allergic conjunctivitis, which is also published right now in our standard treatment guidelines book. Yeah, go ahead, Gauri. You'll have to put on your video. Yeah.
Yes, ma'am. Just one second.
Yeah.
Am I audible?
Yes.
Good afternoon, everyone. Thank you, madam, for that introduction. Today, I will briefly tell about standard treatment guidelines for allergic conjunctivitis, which are under auspices of the IEP Action Plan 2022. As the name suggests, conjunctivitis means inflammatory reaction of the conjunctiva, usually to the allergens. Ocular allergies occur in 15 to 25% of the population. Nowadays, incidences seems to be increasing in recent years as the pollutant concentration is also increasing. Like we are exposed to dust, we are exposed to house dust mite, plus many of the pollutants are increasing day by day in the ambient environment. Out of this cornea, lens, anterior chamber and vitreous, they are all devoid of blood and lymph vessels. So inflammatory reactions occur mostly in the neighboring structure, which is conjunctiva, and it contains mostly mast cells, which are 90%. As we know, these are all allergic reactions, which are because of degranulation of the mast cells, release of all the inflammatory markers or inflammatory inhibitors in the bloodstream, or we can classify this under the headings of allergic conjunctivitis can be classified as seasonal and perennial atopic conjunctivitis. Seasonal means which occurs in specific seasons, like summer season, usually it is seen. Perennial is usually maybe seen throughout the year. Second, we can see subcategory as vernal keratoconjunctivitis or atopic keratoconjunctivitis. Vernal is slightly when the disease is an advanced process, which is also known as a spring catarrh, basically. And third category is giant papillary conjunctivitis. Usually it is an inflammatory reaction to the foreign body in the eye. Most commonly it is a use of those who are using contact lenses or any prosthesis are there in the eye. They have this giant papillary conjunctivitis as an allergic reaction to that prosthesis or contact lens. And last is allergic or hypersensitivity changes on the ocular surface per se, which are going to occur. In every allergic conjunctivitis, there is either a red eye or the pink eye. But usually per se, if we say conjunctivitis, red eye is seen everywhere. But how we will diagnose it, or we can do the differential diagnosis, because the differential diagnosis includes any disease in which the eye becomes red with the symptoms of either burning, itching, and tearing. These are usually the because of the IgE mediated or related reactions which are occurring. Causes can be divided as a differential diagnosis into infectious and non-infectious. Infectious, usually we see viral conjunctivitis, which is commonly seen as an 80% of the cases. It starts usually with unilateral eye and later spreads to other eye within 3 to 4 days, and often associated with mucopurulent discharge with specifically we can see preauricular lymphadenopathy. Secondly, bacterial conjunctivitis, which is common in the pediatric age group. There is a matting of the eyelids, which we say like glued eyed in the morning, which we can see, along with the yellow to greenish purulent discharge is seen. If we examine the eye, it reveals a papillary reaction on the tarsal conjunctival surfaces and punctate keratopathy. Last can be chlamydial conjunctivitis. Usually it is insidious onset and present at least 6 weeks before the diagnosis is made. Many times seen in neonates most of the times. We can give non-infectious causes of allergic conjunctivitis as in contact dermatitis, drug-induced allergic contact dermatitis, drug usually like atropine, benzalkonium hydrochloride, etc. Keratoconjunctivitis Zika, then blepharitis, subconjunctival hemorrhage, and contact dermatitis with conjunctivitis is mainly because of detergents, creams, lotions, cosmetics, or eye drops. Coming to the treatment part, main targets.
Gauri, go a little slow.
Yeah, sorry. Coming to the treatment part, treatment usually we can categorize into three, like we can divide into 3 parts. Like first, treating the symptoms, because the patient is having a lot of symptoms like itching, irritation, then swelling of the eye, redness of the eye, tearing, then prevention of degranulation and treating the hyperemia. General strategies of the treatment like cold compresses are very good because they're helpful in the symptomatic treatment of the patient, which will give early relief to the patient. Also, counseling of the parents along with the children is required, because usually children have a habit of rubbing their eyes continuously. So they should not do it basically when they have this type of conjunctivitis. Cold compresses in the form of ice pack, ice cubes we can use, or just a cloth which is wet with the water, cool water we can use, because that will give a very, very good symptomatic relief. Coming to the drug part, like antihistaminics can be used, which can be either topical and systemic. Tear substitutes are also advised, but preferably preservative-free tear substitutes should be used. Steroids, as already everybody has mentioned, we have to avoid the steroid use. Basically, for the long-term use will cause glaucoma. So as much we can avoid, we have to avoid. NSAIDs, which can reduce itching and hyperemia. Mast cell stabilizers, because usually there's a mast cell degranulation. So we need mast cell stabilizers, which are best for the long-term therapy. Mast cell stabilizers, they include sodium chromoglycate, 2 to 4%, nidochromyl sodium, lidoxamide, olaptadine, azilastine, and epinastine. Cyclosporin A and tacrolimus, sir has already mentioned, because the role is not much, but the topical application reduces the need for long-term steroids, which cases are not responding to the routine treatment. And antibiotics may be indicated in cases of suspected staphylococcal infection. Now we come to the specific treatment part of seasonal or perennial allergic conjunctivitis. Again, the treatment can be divided as a topical agents and some oral agents, and preventive guidelines, which are important in each and every treatment. Now, coming to the topical drops for allergic conjunctivitis, they come in the many different forms. So many preparations are available, but here we outline a general overview or the suggestions of different options. And usually we know, as there is an inflammatory reaction, usually there is a vasodilatation. So of note, chronic use of vasoconstrictive agents, it can lead to rebound vasodilatation when discontinued. So when we are using these drops, we have to keep this in mind. Coming to the drops, first line, usually available over the counter antihistaminics or vasoconstrictor agent. They are first line of treatment. They are inexpensive. Many brands are available containing antazolene phosphate 0.05%, nafazolene hydrochloride, oxymetazoline hydrochloride, or phenylephrine 0.12%. Second line, second generation topical histamine receptors or H1 receptor antagonists. They are more effective than vasoconstrictors, but they are more expensive. The three principal choices are pheneramine maleate, which is 0.3%, amidastrine, and levocabastrin hydrochloride, which is 0.05%. Third line of treatment usually is used for the recurrent or persistent symptoms, which includes mast cell stabilizers. Mast cell stabilizers are usually cromolyn sodium 4%, nidochromyl 2%, 0.1%, and lidoxamide tromethamine 0.1%. And these are FDA approved only for a specifically vernal conjunctivitis. But these should be used only if other classes of medications have failed. We can also go for combined medications like combined H1 receptor antagonist and mast cell stabilizers, which include olaptadine hydrochloride 0.1%, olaptadine hydrochloride 0.2%, or ketotifen fumarate, Elestat, or Optiver. These agents are more effective than the mast cell stabilizers alone. And out of everything, if the symptoms are not adequately controlled, brief course of low potency and low frequency topical corticosteroids can be used. But NSAIDs such as ketorolac has been approved by the FDA for use in seasonal allergic conjunctivitis, but it is generally used as an adjunctive agent. Now, if we want to use any oral drugs, then oral antihistaminics such as levocetirizine, cetirizine, fexofenadine, desloratadine, and loratadine can be used, especially if the patient is experiencing additional systemic effects which are usually seen. Some additional measures can be used as an adjunctive measures to improve symptom management, which are artificial tears to dilute allergens, but artificial tears should be preservative free. Then cool compresses or ice packs, which are basically for the symptomatic relief of the patient. And last but not the least, very important is avoiding allergens, which includes frequent clothes washing, bathing, showering before bedtime. We can refer or consult allergy or dermatology for those who are not adequately controlled with topical medications and oral antihistaminics. Would like to add one more thing about overuse of screen nowadays. Usually inappropriate use of screen or overuse of screen is causing dry eyes for the children. Usually because of dry eyes, they have a habit of frequent rubbing of the eyes, and many a times that is a cause of conjunctivitis nowadays, which is seen. Now coming to the second part, that is vernal or atopic keratoconjunctivitis. The treatment part is, although this disease process is advanced, like in both vernal keratoconjunctivitis and atopic keratoconjunctivitis, which is also the spring catarrh, the general treatment strategies remain same as that of allergic conjunctivitis, that is for seasonal or perennial allergic conjunctivitis. But if, however, an acute exacerbation occurs, then the topical corticosteroids, they are often added to reduce the inflammation. Another adjunctive therapy is addition of topical cyclosporin 2%. If this vernal keratoconjunctivitis or atopic keratoconjunctivitis is not responsive to topical therapy, then supratarsal injection of corticosteroid can be considered as a treatment part. And coming to the specific treatment of giant papillary conjunctivitis, as already mentioned, the causative agent is usually the contact lens or any prosthesis or the foreign body. So the most important management will be modifying the causative entity. So that generally includes either removal or the replacement of the sutures, rotating the knots, or using a therapeutic contact lens which won't cause the allergic reaction like we get the foreign body reaction. I think with that, I have given a synopsis of this allergic conjunctivitis. To summarize, I would like to say many allergens are increasing nowadays in the form of the pollutants, in the form of house dust mite. But I think the overuse of the screen or inappropriate use of the screen is, I think, the major cause today, what we see in the children basically. So the counseling of the parents, avoidance of the allergens, and symptomatic treatment in the form of the cool compresses, and stick to the topical use of the antihistaminics or anti-allergens will be the gold standard, rather than going for steroids unnecessarily or any other type of immunomodulators. Basically, prevention of the allergens or parental counseling regarding all this will be more helpful rather than the drug treatment. Thank you, everyone.
Thank you so much, Gauri. That was lovely. And I don't think we would have read it if we had to go through it on our own. So thank you for this presentation. What I think is that we should stick to oral antihistaminics and some natural cures. But if this thing gets really bad, then we have to refer to our ophthalmologist friends, because the eye being so precious is best looked after by an ophthalmologist. So, but this is very good, especially the part where you said injecting corticosteroids and all that. I don't think that comes in the domain of pediatricians, although it is mentioned over here for us to know. Yeah. Would anybody, is Dr. Srisailak still there, and would he like to say something? Is someone likely to comment on this? Yeah, I think that was very nice. Thank you, Gauri. And we go to a very important topic.
Ma'am, shall
Dr.
I?
Vijay, yeah, please.
Yes,
Yeah, you mentioned that case where
I was just
long-term
listening on the
steroids.
topics. Even the allergic rhinitis also, the speaker, Dr. Ambul Deshpande, he really enlightened. And now also I listened all the conjunctivitis. The latest 2018, the World Allergy Organization has said that 95% of the children with allergic rhinitis always have a hidden signs of ocular allergy. So as a pediatrician, our role is very important. Like specifically hidden signs means dark circles, long eyelashes, then creases under the eyes, that's Muller's muscle spasm or Denny Morgan folds, cervical lymphadenopathy. So as a pediatrician, we should pick up these signs also, because the allergic conjunctivitis, like an asthma also, it has not been given that much importance in the practice. So a lot of children, when they rub the eyes and all, they are having a keratoconus. Because my spouse, Dr. Ushali Varat, she is ophthalmologist and she exclusively is practicing in ocular allergy. And we are seeing a lot of cases. Just now, while having this talk, I have one of the senior pathologists with me from the suburban, and his child is 7.5 years, and he is unable to open the eyes last 6 months. He's having such a significant photophobia. because of the severe vulnerable keratoconjunctivitis. So basically, the allergy management is also important. So these patients, along with the eye steroids and whatever the patient is getting, the nasal steroids are also very important. And specifically in that, the agelastin should be combined above 6 years, because there is a nasoocular reflex, there is a nasolacrimal duct inflammation going into the eyes, and there is a localized sensitization. It is called pollination. So whatever the dust and pollens, the mast cells are so rich over here. 1 cubic millimeter, there are around 5,000 to 10,000 mast cells. So these three ways the ocular allergy plays a role. So not only the local eye steroids or something, we have to always give with the nasal steroids with the proper agelastin above 6 years. And then even the Montelukast levocetirizine or Montelukast bilastine. The bilastine molecule I have found very useful in relieving the congestion, because that is one of the molecule in my practice I have seen as a mast cell stabilizer also. So these can be utilized. It will be really useful, definitely.
Awesome. That was
Yes,
so
ma'am.
nice, Dr. Vijay.
Yes, ma'am.
I just wanted to ask you, what is this molecule? Because nasal steroids, I don't think are available, because we are using ophthalmic steroids for nasal. So can
No,
you?
ma'am. No, ma'am. Nasal steroids are very well used now. Mometazone is there, fluticasone furoate, fluticasone propionate. Then there are a lot of
You mean
now nasal.
inhaled steroids?
Yes, ma'am.
Okay, okay.
Nasal steroids.
No, I was
So,
asking about nasal drops.
no. Nasal steroids means nasal
Nasal
inhaled
steroid.
steroids only
Oh,
with
okay.
agelastin. So that is very useful,
Okay.
definitely.
Okay.
Yes,
Yeah.
ma'am. Yes,
So
ma'am.
for acute relief of eye congestion, would you?
Yes, ma'am. It has been found now, even the World Allergy Organization is recommending that these patients only with a severe ocular allergy can be given a agelastin for a longer period also, depending on the seasonal exacerbation. We can give it for 3 to 6 months also. It is more useful because it reduces the eye steroids, the potent eye steroids to lower potent, or that way also we can come down that way. Definitely.
Yeah. You also presented that child who was chronically using steroids and who developed a cataract.
Yes,
So,
ma'am.
okay.
Even 19 years old girl, she lost the eye because of the optic atrophy, because of the glaucoma. So there are many cases now we are seeing such about, and glaucoma is also very serious amongst these patients. So we can prevent these blindnesses actually, and these cases are increasing. Keratoconus is a very big now, because one of the pediatric ophthalmologist and her husband is a cornea specialist, and their children are getting treatment from me. So he told me previously he used to have one keratoconus lesser treatment or something within 6 months. Now in a twice or thrice a week he's operating those cases. So in the adolescent period and all, because of the rubbing eyes, the children get a problems. So best way to manage it that way.
So you told us some important pointers. You said if they have these dark circles, if they have long eyelashes, and if they have some other crease, you said, or they have cervical lymphadenopathy, these are signs that these children may be having allergic rhinitis and allergic conjunctivitis. Look out for these and do treat it appropriately.
Yes, ma'am.
So
Sure.
I think the message is very clear, Dr. Vijay. Thank you for your comments. And with this, we go to Dr. Nilesh Palwankar for his presentation on standard treatment guidelines by CIAP on anaphylaxis.
Last. I will come to light, madam.
Can everyone mute themselves, please? Can everyone? There is some background noise.
मॅडम माझा आवाज येतोय?
Yes. Yeah, I can.
Madam, can
Yes,
everybody
Nilesh.
hear?
Yes, go
So
ahead.
can I start?
Yeah, please do. We can see your screen also.
So put in here first.
Yeah, I want to introduce Dr. Nilesh Palwankar. Dr. Nilesh Palwankar is a pediatrician neonatologist who is practicing in Nalasopara as well as in Virar. He has his own clinic at Virar, but the most important thing is that he is attached to two very big neonatal intensive care units, both at Tulinj Hospital in Nalasopara and Bolinj Hospital at Virar. We are all very grateful to him for his contribution to the community. Dr. Nilesh today will speak on anaphylaxis. Go ahead, Nilesh.
Good afternoon, everybody. Today I'm going to read the IAP standard treatment guideline for anaphylaxis. So anaphylaxis is emergency condition, and then we should know very quick thought process has to be there when there is anaphylaxis. Then I think IAP has given us a guideline, so it will be easy for us to think when there is a case of anaphylaxis. So this guideline, they have put it in 7 or 8 points. So first they are telling about the definition, then the diagnosis, then what are the precipitating factors, what are the lab parameters, what are the differential diagnoses, how to manage, how to monitor, when to admit the patient, and what is the home action plan. So first we will start with the definition. So the definition says that it is an acute clinical syndrome, which is characterized by severe, life-threatening, generalized type 1 hypersensitivity reaction caused by exposure to a foreign substance, leading to a mast cell degranulation and release of a chemical mediators. So what definition try to tell is it is always an acute condition and it is always a life-threatening. So we have to act quick, but to act quick, we have to do the diagnosis quickly. So they have made 3 criteria for diagnosis of anaphylaxis. So first criteria is for unknown patient who is not known to allergy, and second and third diagnostic criteria is patient who is possible possible patient for allergy, and third patient is known for allergy. So first criteria, what they mentioned is acute onset of an illness with involvement of the skin, mucosal tissue, or both. So either it can be a skin or a mucosal tissue alone, or both, and at least one of the following. So respiratory compromise and circulatory compromise. So that is for a patient who is not known for allergy. Second criteria is likely allergen for that patient. So 2 or more of the following that occurs acutely after exposure to a likely allergen. So in first, you don't have any hint. The patient is suddenly coming with some skin manifestation, mucosal tissue swelling, and then respiratory and circulatory compromise. Here you don't try to find, or you don't know the allergen. In second, so there is a possible exposure of allergen. So in that also, again there is an involvement of the skin, mucosa, respiratory compromise, circulatory compromise with persistent gastrointestinal symptom. In third criteria, symptoms are acutely after exposure to known allergen for that patient. And along with that, what they have mentioned, reduced BP, defined as low systemic blood pressure for that age, or less than 30% decrease in the systemic blood pressure. So what I want to say, like, they have made this definition into 3 categories. One, you don't have any clue to the allergy. Another, there is a possibility of allergy. And in third, he is known to allergy. So this definition we have to understand in detail. So a patient maybe he is having good history of allergy, or he may not have a good history of allergy, but it doesn't exclude the anaphylaxis. That is that's why they have mentioned it. Like if you try to read in between the line, so they have categorized these patients into 3. So one is known, one is possibility, and another you don't have any other clue for allergy. So what is the acute onset? They have defined that it will happen within minutes to hours. What is the definition of involvement of the skin and mucosal tissue? It is generalized hives or urticaria, pruritus, flushing, swollen lips, tongue and uvula. For respiratory compromise, it is very easy, like you are having difficulty in breathing, stridor, low saturation. In circulatory compromise, it includes low blood pressure and associated end organ dysfunctions like hypotonia, collapse, syncope, incontinence. In GI symptoms, crampy abdominal pain, vomiting. In low systemic blood pressure for children, they have defined less than 60 millimeters of mercury, birth to 1 month, less than 70 millimeters of mercury from 1 month to 1 year. Then from 1 year to 10 years, 70 millimeters of mercury, 2 into age, and for more than 11 years onward, it is 90 millimeters of mercury.
Next slide.
So then we will go to the precipitating factors. So precipitating factors can be internal or external. So for internal, like drug ingestion of like antibiotics, NSAIDs, aspirin, food. In food, more common, I have come across like after eating prawns and eggs, mostly I have come across. I have hardly seen anybody with what in foreign countries they are having like peanut allergy. So I haven't seen. One of my sisters, she is having a proper, like if she eats an egg or if she eats something related to it, then she is having severe abdominal pain and she is in difficult situation. That one case I know from my family. Parenteral administration of the drugs like antibiotic, paralytic agents, opioids, propofol, insect bites and stings, contrast media, vaccine, blood products. Contrast media will come across like when you advise MRI or CT scan with contrast, that time you have to be very careful. You have to take the history of any allergy. Physical contacts, latex and others, exercise in cases of FDEIA, that is food dependent exercise induced anaphylaxis. Lab parameters, actually nobody is having that much time to think for lab parameters, but if somebody is interested, then they say you go for serum tryptase and then you compare like what is the difference between the before and after, and then you can rule out other rare causes like mastocytosis and pseudoanaphylaxis. So I think it is just for theoretical purpose. Now for clinical purpose, what we can get confused whether the patient is coming to us whether he is having anaphylaxis or vasovagal attack. So if you want to quickly differentiate, then simple way you see whether he's having tachycardia or bradycardia. So tachycardia and bradycardia is a simple way, and another you look at the patient. If he's pale and cold, then mostly it is vasovagal. And if it is having red hot wheals with itchy rashes, then it is anaphylaxis. GI symptoms, nausea, vomiting in anaphylaxis. In vasovagal, it is non-specific. What we do usually in our OPD, like we give the patient a prone position. If he improves, then it is a vasovagal. If he doesn't improve, it is anaphylaxis. And the treatment of choice is IM adrenaline for anaphylaxis, vasovagal. So a simple way, like if you feel the patient is pale, then it is vasovagal, and if it is like red hot, and it is an anaphylaxis. So I think this is a simple way to differentiate. Then we'll go for management. So I think I have gone through the algorithm. I have to read the algorithm because I have asked to read, but it is very difficult to follow the algorithm when you are in that situation. But let's go through it once. So management algorithm, what say if patient is satisfying any of the 3 criteria as mentioned above in presence of known trigger or a precipitating factor, then we have to suspect anaphylaxis. So they have done in 1 minute, 1 to 5 minutes, 5 to 10 minutes, 10 to 20 minutes. In first minute, what you should do? Keep supine position, sitting position if respiratory distress, nausea, vomiting. Assess airway, breathing, circulation, heart rate, BP, saturation, provide oxygen 10 to 15 liters by NRBM, identify and remove the allergic trigger if possible. And then important things come, administer first dose of IM epinephrine. Now epinephrine and adrenaline is same. In Western countries, they say epinephrine. In India, we call it as adrenaline. So 0.01 milligram per kg per dose. So now there is preparation in the market which is there 1 milligram per ml. So it is 1:1000 dilution at anterolateral aspect of the thigh. So yesterday I have calculated. See, for pediatrician it is easy to remember 10 kg. So I have calculated. So for 10 kg it will be 0.1 ml. Okay, so if the child is 10 kg, you give 0.1. If child is 20 kg, you give 0.2. If child is 30 kg, you give 0.3. So I have sat down, I have tried to calculate. So then I realized if we remember 10 kg, then it is simpler. Then if it is 15, you give 0.15. And you can repeat that those 5 to 10 minutes interval as needed.
Nilesh, can I say something? On the
Yes, yes.
1 TU per kg. 1 tuberculin unit per kg.
I
1 TU.
1 TU.
1 TU per kg. So 3 kgs.
Maybe.
10 TU.
Yes, yes.
Yeah.
Yes. Only my question, like whether we should dilute it or not, because
No
like
dilution. No dilution.
Yeah.
It is given just like that.
Yeah,
so-
only thing that much amount should penetrate
so
to the
1 TU,
patient and
yes.
it should go.
Yeah, so 1
Like
TU
if I
should go. Correct. So after you have aspirin,
Yeah.
you can dilute it. Yes.
Yeah, that's what I'm thinking. Like 0.3, it should reach to the muscle, and then already baby is in hypotension, it should receive also. So my
Correct.
question was like, with 0.1 cc, it will go through that syringe, and then it will pass the needle, it will go to subcutaneous tissue, and the muscle from there it should get absorbed also.
Yeah.
So I feel there should be some dilution, so it will penetrate and it will get absorbed. That is, I think, logical. Nothing great about it. What they say, it can be repeated every 5 to 10 minutes interval which is needed. After 1 minute, we have to go to the next, like what to do from 1 to 5 minutes. So from 1 to 5 minutes, they are telling you have to go for you analyze the patient. Like now you have given epinephrine. Now rest, like you give sitting position, then you give high flow nasal cannula oxygen. Then now you assess whether he is having stridor or wheeze. So if he is having stridor, again you give first nebulized epinephrine, 0.5 ml per kg. So like what I have calculated, if patient is having stridor, so you have to give epinephrine 0.5 ml per kg. So what I have realized, for 10 kg, you have to give 5 ampules. Because 1.5 ml per kg. So 1 ampule is 1 ml. Okay. So if a patient, one epinephrine, 1 ml, one ampule is 1 ml. So for 10 kg, you have to break 5 ampules and put it and give nebulization. Okay. For wheeze, they are saying first nebulize with salbutamol. Nowadays, salbutamol is not available. So everybody is having diolin. So now I have checked the diolin. So diolin having levosalbutamol, which is 1.25 milligram. So like for 10 kg, if you give 1 diolin, it will suffice. So what I'm trying to say, like if 10 kg child is there, yeah, you break 5 ampules and give nebulization if there is a stridor. And
please mute yourself. Dr. Amay Deshpande, please mute yourself. Yeah.
And if wheeze is there, for 10 kg, 1 diolin is enough. I don't know whether salbutamol now, if anybody is keeping. So I don't know whether only salber is available and if somebody is keeping.
Yeah, Astalin.
Yeah, Astalin.
Yeah, you can use Astalin or levosalbutamol.
Yeah. So for I think 10 kg, quickly we another question I was thinking whether we put two together stridor, if stridor is there, and how stridor and wheeze can be differentiated, or we should put both together and go ahead. So that is another question. Hypotension, poor perfusion, loss of consciousness, it is easy, like what we have been taught, give normal saline 20 ml per kg by IV or intraosseous rapid push technique. So like this you have to do in 1 to 5 minutes. So first thing you have to do is put epinephrine. Then you try to go for stridor, wheeze, and then IV. So first we have to go for IM epinephrine. That is the crux. Rest of the things can be tackled. But if we miss the adrenaline and if we go for Avil, and then if we go for hydrocot and oxygen, it is not going to help. The drug of choice is epinephrine. So if you feel anaphylaxis is there, you don't do anything. First find adrenaline and give it, and then rest of the thing you can manage. So crux is adrenaline. But I think most of us they run for Avil and hydrocot. So that it is not mentioned, avyl hydrocard not mentioned anywhere. So in next 5 to 10 minutes, what you have to do, now you have to assess what if you have done, you have given adrenaline, you have given oxygen, epinephrine nebulization. Now patient is not improving, then there is a second dose of epinephrine. So IV or intraosseous access to be established. So what they say, first you give first dose, wait for 5 minutes, then again, if it is no improvement, give second dose. Then again for respiratory distress, you have to repeat like second dose of epinephrine. If hypotension is there, then you give bolus. So what you did in 1 to 5 minutes, same you have to do in 5 to 10 minutes. So now we are going to next 10 to 20 minutes. Now after 10 minutes, you are coming to the fourth stage. Now what you have to do? If no improvement, then again you have to repeat third dose of epinephrine. So first minute, first dose, 1 to 5 minutes, you assess what adrenaline you have given, whether it is acting or not. If you feel it is not acting, 5 to 10 minutes second dose, then you again wait for 5 minutes. So now 10 minutes are over, no improvement, you have to go for the third dose of epinephrine. If no improvement, give third dose of epinephrine, IM, okay, same, third nebulization, and then for respiratory distress, again nebulization. For hypotension, again, this time what they say, start giving IV epinephrine, 0.05 microgram per kilogram per minute, we titrate by 0.02 microgram per kg per minute up to effect. See, it is very easy to write, but when you have to pass it on to sister, then what you will do? So I don't know, I have done some calculations, it may be correct, it may not be correct, I don't know. So what I have realized, if you want to tell your sisters to start a epinephrine adrenaline drip now with this, so you have to tell her to give 0.7 ml for 24 hours. Okay, so 1.5 ml in 48 hours. So what you can tell your sister, sister तुम्ही 1.5 ml adrenaline घ्या, ते तुम्ही 46.5 cc मध्ये dissolve करा, 1 ml per hour ने तुम्ही चालू करा. See, knowing 0.5 microgram per kg per minute, how you will calculate when the patient is bad? Okay, so for 10 kg, you should tell sister take 1.5 cc for 48 hours, 1 ml per hour. So 1.5 ml of epinephrine in 46.5 cc of whatever, like 5% dextrose or whatever. And then you run 1 ml per hour. And then what they say, 0.2 microgram per kg minute, you have to increment. Then you tell ki baba 1 ml ni na improvement hota, we will go to 1.2 or 1.4, 1.5. So I have calculated everything and I have come to this is I think little tricky. 0.05 microgram ते कुठे लक्षात राहणार आहे आपल्याला हे सगळं. So you can recheck from your side ki whether 1.5 cc for 48 hours for 10 kg is proper or not. So I have calculated for myself. So if there is situation, I'm going to go ahead with this. So you can recheck what I'm saying from your side. Then we'll go ahead. Then you have to transfer the patient to pediatric ICU and tertiary care center. If there is no improvement, suspect refractory anaphylaxis, then again there is a role of IV non-epinephrine. Now what you have to understand, initially it is epinephrine. Now you have to turn to non-epinephrine. Okay? And the formula is same. For 10 kg, 0.7 ml for 24 hours, 1.5 ml for 48 hours, run 1 ml per hour. IV glucagon I have never come across. So I don't know how to give IV glucagon bolus, 20 to 30 microgram per kg per dose over 5 minutes, followed by 5 to 15 microgram per minute, titrated till achievement of clinical effect. If patient of anaphylaxis is there, we are going to forget all these things. What we are going to remember is adrenaline, which is easy, 10 kg, 0.1 cc. Follow up what they say, like you have to be very careful because sometimes there is a delayed anaphylaxis, maybe due to biphasic reaction. which generally occurs within 1 to 72 hours after initial improvement, or protracted variety, which is severe persistent anaphylaxis symptoms for 24 to 36 hours despite aggressive treatment. Monitoring of vitals along with respiratory symptoms should be done over minutes during first 30 minutes, and then hourly for next 24 hours, and then 2 hourly for next 48 hours. Follow-up of patient should be done for at least 4 hours after last IM epinephrine injection, and in severe hospitalized cases for minimum 3 days. So only thing, if you treat the patient, you may feel he's improved, but then sometimes there may be a biphasic reaction. And I think rest of the things are a bit logical. Nothing like you can have your own ideas for follow-ups. So what are the indication of hospitalization? Tachycardia, hypotension, stridor, wheeze, tachypnea, low saturation, severe protracted anaphylaxis, comorbidities, live in remote area, present in late in the evening. So I think practically I feel live in the remote area and present in the late evening is more practical. Why other things are going to be there a bit like stridor, wheeze, saturation, but like if patient is coming from remote area, it is better you ask them to be with you. I think that is take home message. Now, what is the home action plan? I think home action plan, it is more required in the Western countries. Like if they are having some allergies, so usually they are having EpiPen. In India, it is not available. EpiPen, green color 0.15 milligram and yellow color 0.3 milligram. It is ideal, but it is limited resources in India. Home prepared IM epinephrine. So injection is 0.01 milligram per kg of 1:1000 in 1 ml syringe over anterolateral aspect of the thigh may be a practical option. So 0.01. So again, it is coming to 0.01. So it is 0.01 milligram. It is like 0.01 cc per kg. So 0.1 cc for 10 kg. So it can be kept for 3 months at room temperature with protection from light. Expiry date should be written for the future reference. And call your state emergency number. National emergency number is 112. So, key learning point, anaphylaxis is sudden, severe, life-threatening allergic reaction to allergen with multi-system involvement. Early identification, management are the cornerstone. IM epinephrine is the drug of choice. Follow-up of patient for minimum 3 days due to a biphasic nature of anaphylaxis. Education of parents about its early recognition and appropriate management in the need of hour. So what I personally feel now, we are having that spinal reaction, avil and hydrocot. So if we are thinking of something odd now, like if you are not comfortable with the patient's behavior, you have given antibiotic, like sister has given some antibiotic and patient is telling I am not feeling well, I am uneasy, I am having vomiting. You don't give Rantag, you don't give avil hydrocot. It is better you give IM adrenaline, which will save your skin. Like if you give avil hydrocot, then the things may be different. Like for sisters also, na, avil hydrocot is the thing. No. Avil hydrocot is anti-allergic. They are not like good in anaphylaxis. But how you will come to know whether he is allergic or he is landing into anaphylaxis? So when we are practicing in our hospital and if sister coming suddenly, sir बघा काय करतोय तो अचानक वेगळा वागतोय, so you go and see, and if you feel there is something different, better you give adrenaline. 0.1 ml adrenaline at the most, what it will cause tachycardia and then perioral whiteness or something like that. But if you miss anaphylaxis and if you just give avil and hydrocot, so we may miss the bus. So I personally feel ki avil hydrocot peksha we should think of adrenaline in our indoor patient if there is something going wrong. And 10 kg la 0.1 ml. That should, I think that should be, we should fix in our mind. कारण मी most of the time I have seen डोसचा गडबड होते, मग देऊन टाक काहीतरी 0.3 cc दे ग, मग ते dilute कर. So I think keeping 10 kg 0.1 ml is better. And if the situation is bad and if you have to start with adrenaline, then I will say for 10 kg 1.5 ml 46.5 cc, 5% dextrose, you start 1 ml per hour, and at least you can shift if you have to start with either adrenaline or noradrenaline. So I personally feel 4 drugs, two things you have to keep in mind. I am adrenaline and then adrenaline nebulization. These 2 things are very important. Invariably, you are going to give salbutamol. That is okay. What you have to keep in mind is adrenaline nebulization, how to give 10 kg, 5 ampoules you have to break, and IM injection antrol aspect 10 kg la 0.1 ml. If the situation is bad, give normal saline, start adrenaline, noradrenaline drip, and you can send the patient to higher center. So I think guidelines are there, but then these guidelines you have to make it practically possible in a simple way to fast track. So मी काल बसलो आणि जरा थोडेसे कॅल्क्युलेशन केले आणि आय थिंक प्रॅक्टिकल टिप्स आर मोर इम्पॉर्टंट दॅन गाइडलाइन्स. गाइडलाइन्स आर ऑलवेज देअर फॉर द स्टुडंट्स. For practitioner, they need practical tips. You know everything, blah 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 blah. बऱ्याच गोष्टी आपल्याला माहित असतात, पण पेशंट समोर आल्यानंतर नक्की काय करायचं हे मेंदूमध्ये फिट व्हायला पाहिजे. So day before yesterday, sir told me to go through the guidelines, and then I have read, then I realized कि फार ते complicated है. Then, but you can correct yourself if I am wrong. But I think that is the take-home message. I am adrenaline, 10 kg, 0.1 ml. If you feel stridor, then 10 kg ला 5 ampule फोडा. त्याच्यानंतर 10 kg ला तुम्ही नेब्युलाइज करा 1 डिओलिनी, आणि नॉर ऍड्रेनालिन किंवा ऍड्रेनालिन साठी तुम्ही 10 kg बाळाला 1.5 ml 46.5 cc मध्ये डिझॉल्व्ह करा, 1 ml per hour ने चालू करा आणि हायर सेंटरला रेफर करा if the situation is bad. And I don't think so. I have read it. There is no role of avyl hydrocot. So I think some expert is there. They can comment whether there is a role of any avyl or hydrocot in the anaphylaxis. So with that, I will try to finish this topic. It is a wonderful topic, and the presentation slides are very good. But see, when in practicality, is very difficult with the 0.05 microgram per kg per minute, then increment of 0.02 microgram per kg per minute. So smartly we have to find out our way, and you have to tell your sisters, you can put it somewhere in the wall, how to give adrenaline. That's what I feel personally. So I am not very theoretical person. I am not very academician, but I try to give the message how to use adrenaline, noradrenaline in anaphylaxis, because rest of the things we know, but how to act in emergency, that is more important. So anybody has any question, then experts are there to answer. I am not the expert person, so I am like more practical oriented. So I am not good in academics. So if somebody is having any question, they can ask others who are participating.
Thank you so much, Nilesh, for all your practical tips. And I'm so happy that you have given very practical dosages. And if Dr. Vijay Varad is there, we would like him to comment, especially about this EpiPen injection. It's not available. So what we have done in our hospital is we have a box prepared for all emergencies. And one of the box we have prepared is for anaphylaxis. We keep adrenaline injection, a tuberculin syringe, and we have kept a tuberculin syringe always filled with 0.5 ml of adrenaline in that. And the dose we give is 1 TU per kg. So if the child is 10 kgs, we give 10 TU and we aspirate it till 1 ml and then give it intramuscularly. The maximum dose is 0.3. We have also kept a Venflo and IV set and IV fluids in the same box, so that when the patient comes, these are the only things that we have to use, that is injectable IM adrenaline in the dose. And we have written on the top the dose also, so that a sister doesn't have to be there, or nobody, no RMO has to look for what to give. So the box has the doses written on that, and it has all that is required for the emergency in the box. So we have adrenaline, tuberculin syringe. We have a tuberculin syringe filled with adrenaline with the date written on it. We have normal saline. We have IV fluid in that, and the dosage written in on this. I will send a picture of that later on. So this is what we have done. We have done similar boxes for snake bite, scorpion bite, for other emergencies as well. So thank you very much, Dr. Nilesh.
Madam, I want to experience my our own experience. Like we had one girl who used to come to us for this Penidura injection, and for many years we gave her a Penidura. Many years, so she was our regular customer. One fine day, Anuradha was there in OPD, and she has given Penidura injection, and suddenly the girl started behaving differently and suffocating. So what we did, तेव्हा कुठे डोस वगैरे लक्षात होता आम्हाला. आम्ही ॲड्रिनालिन घेतलं आणि आम्ही टोचलं तिला. I am adrenaline. I don't know what was like half cc, or she was quite big girl. But yeah, with one dose of adrenaline, everything starts settling down, and I think in next 3-6 hours she got settled, and we were about to lose her. That like she was around 13-14 years, and we have seen anaphylaxis, and we were about to lose her. Parents also got frightened. Her face became something different. She started, I think she had a GI symptom and suffocation. It is like 5-7 years back. But then only adrenaline saved us. Otherwise, we would have gone into big trouble. So one case at least of anaphylaxis I have seen. Anuradha came running. अरे बघ काय करते ती, कसं तिचं बिहेवियर बदल. अनु सोड, तू ॲड्रिनालिन इंजेक्शन दे. And then the things settled down. So she still we remember Anuradha, she told me, बघ ना काय करते कळतच नाही. म्हटलं तू बाकी सोड, तिला ॲड्रिनालिन इंजेक्शन दे. And
excellent
that was a
management,
big
Dr. Nilesh. Excellent management, and any child who has can you hear me? Yeah, excellent management, I said, Nilesh. And any child.
Madam, we can hear.
Yeah, excellent management, Nilesh. And adrenaline, I can see Dr. Pramod Vankede, who is the president of IAP Raigad. Dr. Pramod, please, your expertise.
Yes. Thank you, madam. Thank you very much. Just I want to ask one question. You said that about tuberculin syringe. The needle is fixed in that, and it's very, very small. So how we can do intramuscular?
No. The tuberculin syringe we have. Insulin syringe has a needle fixed in that. Tuberculin syringe is a removable syringe.
Whatever we are using for BCG.
BCG, huh?
Yes, that's fine. Yeah.
The 1 ml syringe for which we use for BCG.
Yeah.
Which we attend, that we have to use.
Yeah.
Thank you.
And also any child who has a skin rash along with systemic manifestation of either cardiovascular, respiratory, or abdominal. So anyone who says he has difficulty breathing, anyone who says he is experiencing tachycardia who comes collapsed, or anyone who has a severe abdominal pain, vomiting, retching following any ingestion or yes, Dr. Nilesh, we too had a child who took Penidura for several years, but one fine day he said, I'm feeling tightness over here, and he had gone home and he came back, and luckily we could save him. I had a classmate who used to take Penidura for rheumatic heart disease. She died in the OPD because of anaphylaxis. My own son developed severe urticaria once when we were in a play, area. So keeping EpiPen is important. We don't have it here, but I remember a case of an anesthetist who was allergic to chickpea, to watane, besan. And one fine day, he just went to a party and had chole. He went for a case and he said, I'm feeling breathless, but he continued and he collapsed and he died on the way to hospital. So that is the importance of anaphylaxis. So please, we should take this very seriously. All of us should be ready with adrenaline in our adrenaline, oxygen, IV fluids. Dr. Vijay Varad is here, and please your comments.
Yes, ma'am. Actually, even like tuberculin syringe, that's good. But even now, the IAP's allergy chapter also, Dr. Nagaraju also must be knowing. So we had a lot of discussions on that. The normal 2cc syringe also can be used very well. And even remaining some dead space also we talk, but nothing happens with that. we can get very safely. I am keeping myself 2 cc syringe only with a normal 24 needle I am keeping regularly with me. So that two needles can be kept. And then even there is a study done in India now that can be kept for 9 months also together. It's not only 3 months. We can keep it for 9 months. The discoloration till it happens, we can use it very safely. And as you rightly said, ma'am, previously I used to have within a 6 months one anaphylaxis patient, but now at least 2 patients in a week I am getting with anaphylaxis. And very uncommon, so many even drug anaphylaxis to food anaphylaxis. Even the food anaphylaxis has increased in India. The preservatives are added into the food. That's why the specific IG testing helps a lot. Like I will give 2 examples. One was a 17-year-old girl with a prawns anaphylaxis after eating sushi outside. So they were very curious on that. So I did a component result diagnosis. So in component result diagnosis, basically we can identify exactly the peanut also ARA1, 2, 3, 4, 13 epitopes. In the prawns also different of epitopes. Cockroach also blah 1, 2, 3 that way. Even egg also gliadin, different type of epitopes. So we can predict the patient ki really he is anaphylactic to that or the additives. The same way that girl actually did not have that prawns epitope for anaphylaxis. And when I told them, then they said, yes, at eating home, she never had a problem. But whenever she eat outside, she had a problem. That means that some sulfites or preservatives also can cause the problem. So that way we can differentiate now, because there should not be any hype of anaphylaxis also, because people, if they get some urticaria or angioedema, they go on the Google and they get really scared, and unnecessarily they take so much precautions also. So that way also it should not happen, and we should be prepared also, both way. So we should be prepared, and unnecessarily the people also should not be scared. So now such type of patients with a food allergy, now we can do the specific component result diagnosis. Hardly 5 ml syringe blood, centrifuge blood can be sent to us with a cold chain in ice packs and all. So we give the exact key, the patient is risky for the anaphylaxis because of that food, or there are additives or something. Third thing is that suppose documented the patient has a food allergy, suppose besan, pasur, in Indian scenario, sesamic seed, a lot of allergies I am seeing, sesamic seed also. तीळ आपण ज्याला म्हणतो, त्याच्या anaphylaxis patient पण वाढलेले आहेत. Even coconut anaphylaxis, corn anaphylaxis. So these patients, if they have a documented history of anaphylaxis because of some food, and accidentally they consume that food, so we should not wait till the patient starts showing symptoms. So now it has been found, if the patient accidentally consumes it, they should take adrenaline at home only, and then they should rush to the hospital rather than developing the symptoms. Because once the multi-organ involvement happens, like a dengue or something, it's difficult to reverse the patient. The same way in these patients, when the multiple organ involvement is there, then the adrenaline doesn't work also. And it takes a lot of time. Because there was a case discussed in Sassoon, that patient had anaphylaxis and late stage he was brought. So that time they had to give adrenaline hydrocot 75, 80 and all. The patient had already developed the blebs and tracheostomy was done that way. So the food allergy patient documented, and suppose he has already severe history of prior, if he consumes accidentally, please ask them to give adrenaline and then only come to the hospital. That's better way. Yes, ma'am.
And this happened to an anesthetist, which was so sad.
Yes, ma'am. Yes.
So, yeah, we can't hear you. We can't hear you.
So can we get the EpiPenem injection from outside to India?
Yes, yes. Now, 2 places like Bangalore and Mumbai also have Bridge Candy, something they are getting it available.
Wow.
And now in Delhi, Pedicon, some company has declared that within 2-3 years, till 2025, we will get a ready-to-use adrenaline in India also. That's a good part.
Very
And even
nice.
that syringe is reusable, something that can be refilled, something that was presented.
Excellent.
Yes, ma'am.
Excellent, excellent. So many new things you have added, Dr. Vijay. Your presence has been invaluable to us. And I thank all the presenters today, Dr. Amay, Dr. Gauri, Dr. Nilesh. You all have worked very hard for this. And Dr. Vijay, your inputs have been very, very invaluable. I thank all the office bearers of the various IAPs. I thank Dr. Pramod Wankede for joining in. And I thank everyone who has been present over here right from 3 p.m. and for listening so patiently. I'm sure we have gained a lot from this. And we are meeting again next week on the 28th of December, next Wednesday at 3 p.m. again for case discussion. So we are going to have many cases, and as well as one more standard treatment guideline. And also we are going to discuss the epidemiology of what we are seeing these days. So we've been seeing measles, we've been seeing mumps, and there are a lot more other things that we are seeing more commonly. So we are going to discuss the epidemiology of this. I request all of you to join in again. And thank you very much, all speakers, all participants. I thank Vaibhavi for being the host for today. I thank Dr. Anuradha Palwankar for working very hard, relentlessly with the MMC to get us credit points. And I thank everyone who has been instrumental in today's. Thank you very much.
Thank you, madam. Thank you very much.
For being there.
I want to announce one thing, that we have got very important session today.
Yeah,
on
tonight.
UTI, and UTI by Pankaj Deshpande.
Yeah. Dr. Pankaj Deshpande is also part of our group, and we're all going to join in at 9 p.m. Yes.
Yeah, you are welcome, ma'am.
Yeah, UTI and office practice. Yeah.
On this occasion of allergy, I would really thank Anuradha and Nilesh, who had managed one case at our place with who was rheumatic heart disease. And feedback to be given is that child is better now, and she's a mother to another child now. She had stopped Penidura after that incident, and she was on Pentid. But then Pentid also she was not able to tolerate it. Yeah, she stopped everything, and now the child is doing well, and now she's married and having a daughter also.
Excellent.
Timely management of Nilesh and Anuradha had saved that child.
Lovely.
Thank you.
In absence of Bharat sir and Bharat madam.
Yeah, thank you. So we meet next Wednesday.
Yeah, ma'am. Thank you.
And tonight, we meet tonight for Raigad IAP.
You are welcome, ma'am.
Yeah.
You all are welcome. Thank you.
Thank you.
Thank you.
Thank you.